Doctors, we are live now.
Great. Good day, everybody. It's really a proud honor for me to invite you all to join us for this very first meeting of 2021, a year where we thought we'll be out of the COVID-19 pandemic, but unfortunately, we're still right in the middle of it. It gives us great honor to invite the notable speakers from all around the world to share with us the experiences on managing ophthalmic trauma in this challenging period, hoping to learn from each other and to have the greatest speakers, including Professor Tamara Fountain from America, Gary Regaud from American Society of Ophthalmic Trauma. We have Professor Hoyan representing Asia Pacific, Professor Jeannie Giampolo representing the European Society, and Dr. Hugo Ocampo representing APTO. And one of the best speakers I've listened to is Dr. Jan Tolma from Africa. So I will let Dr. Professor Natarajan, President of APOTS, to say a few words.
So as I said, have a great day. And as I said, good morning, good evening, good afternoon to everybody, because we are having all the continents here. Thanks to the excellent work with passion done by Gangadhar Sundar. So I have some nice moments to share as the President of Asia Pacific Ophthalmic Trauma Society. And I'm glad that he introduced the word ophthalmic, and that's the reason we're all together. So the word ophthalmic is there, and I think it's only in the Asia Pacific Ophthalmic Trauma Society. I don't know about ASOTS, American Society of, I think it's Ocular Trauma, I think. Even India is a Ocular Trauma Society of India, which we celebrated this year, 25 years. So I wanted to tell, as a child, I was assisting my dad. I know it is not a child labor, but I did it with love. Late Professor Dr. N.S. Sundaram during his OPD, and I helped him by holding a torch while he examining the patients to remove the corneal foreign bodies, because there were about hundreds of, not 100, maybe 10 to 20 a day was happening. And this is how I got my passion. I used to ask him, why not we prevent this trauma as a kid? And then this was born in 2011, thanks to Professor Azad, Professor Carolyn Chi, who's here, Professor Gangadhar Sundar, and Professor Dr. Rupesh Agarwal. We are the founding members, and I'm glad we discussed over from, I think, the Asia Pacific Academy of Ophthalmology meeting in Sydney, which was a few years before, and it took some time to get this on. I'm glad finally it was born in the year 2011, and we are registered in Singapore, and all the groundwork done by Ganga, Rupesh, and Carolyn Chi. And our objective is to advance the knowledge in the field of ophthalmic trauma, to set the tone for subspecialty care in the field of ophthalmic trauma, to formulate general guidelines through evidence-based medicine. And the mission, build a network and team of eye care professionals with special interest in ophthalmic trauma to advance the clinical care, science, and research in ophthalmic trauma. And we have this as our APOTS council member. I'm proud to say we have Dr. Rajvardhan Azad, that's President Emeritus, who was the founding president, and myself as president now, Tuan, Vice President, Rupesh Agarwal, Secretary General, Carolyn Chi, Treasurer. We have a very young Carolyn Chi here, even now she's young. And then we have Gangadhar Sundar, Lingam Gopal, the councillor at large. We have Dr. A.K. Grover, Dr. Andreas, Dr. Annette Hoskin, Mehul Shah, Mohan Rajan, Kakan from Pakistan, Manish Papai, and Kendrick Shea, the Joint Secretary. And we also have the other council members, Rekha Kandilwal, Dr. Vivek Dave, Uni Airavati, Dr. Eli, who's organizing a meeting with the SARC Academy, which is going on, Shanti Vosere, and Syed Kadir Mehboob, and Dr. Veeramani Pondiviran from Malaysia. So the activities, we have meetings, we have CMEs, research, collaborative studies, and we have events. And this Dr. Gangadhar will be covering, and I think this was the JEC's Jakarta Eye Center. I'm glad we have the team, and then we had with Giridhara Institute, we had the APOTS ISOT Advanced Ophthalmic Trauma Symposium, and which was in the WC. And you can see, I'm glad that myself and Ferenc Kuhn are generally involved in managing ophthalmic trauma symposiums in the World Congress, and Ferenc Kuhn is a great, passionate surgeon who repairs trauma. I won't call it traumatic surgeon. He's a surgeon who's really goes into the how to repair ophthalmic trauma, and I think it's very important to learn from him. And then we had the first annual virtual resident, thanks to Rupesh, who put us with Gary, Fasika, and Grant. And we had a Ferenc Kuhn, Amy, Robert, and James in that. And we had this APOTS, and thanks to having APOTS along with Wilmer, we also had Ocular Trauma Society of India, where they gave me the chance to do with the as an international ophthalmic trauma webinar one as a part of the silver jubilee of ophthalmic. This was you can see the Gangadhar Sundar, and we see the in 13th to 16 June in Nice, France, in Singapore, in the Society of Ophthalmologica Europa. And then this was in All India Ophthalmic Society. We see Dr. Azad, Dr. Grover, Dr. Rajiv Raman, Dr. Namrata Sharma, Dr. Purendra Besan. And this is in the APOTS at AAO. And you can see Fasika, you can see Rupesh, Ferenc Kuhn, Annette, Gangadhar, Kendrick, Andreas, and many others. And you can see, and this was the AO 2019 Team Trauma. You can see the eyeballs below, like footballs. I'm glad Ferenc is standing behind. Otherwise, he would have kicked one of the balls with the like eyeball. And you see the that time during the meeting, we had Dr. Hugh Taylor, the president of ICO then, and we also have the APO 2012 Bangkok, and you see the one of the board meetings. And then we have this 47th annual conference of the Ophthalmic Society of Bangladesh, tackling ophthalmic trauma along with the APOTS. They called it as the BOSS session. That's the Bangladesh Ophthalmic State. And you can see our members and this taking part. And then we had this TraumaCon 13th to 15th July, which was a grand meeting where Ferenc Kuhn gave the oration. You can see Ferenc Kuhn giving that oration along when Carolyn Chi is taking notes. And then we see Professor Huan here with Carolyn Chi, Gangadhar Sundar, Mohan Rajan, and Annette in the Xi'an meeting. And he's the president of the Chinese Ophthalmic Trauma Society called the COTS. And along with APOTS, thanks to him, he also hosted the first and second APOTS meeting in Shenzhen. And then that time. And this is Gangadhar Sundar's home. And you can see all of us totally controlled by Gangadhar Sundar, who is the scientific chair. And this is during the 3rd to 6th November 2016. And this was at his home. And then we also have Ferenc Kuhn, and we have our dear friend Tamara, which was taken in, again, 2016, 4 years back. I'm glad we have myself as President APOTS, Tamara as President AO, Gangadhar Sundar as the secretary, the scientific chair, and Ferenc Kuhn as the president of the ISOT, the International Society of Trauma. This is in a restaurant, and it's famous. We keep meeting. And the other one is Busan, when Dr. Azad was announced as the president-elect of the Asia Pacific Academy of Ophthalmology. And this is again with Dr. Awa Hussain, who's president-elect in APAO. You can see Dr. Stefan Serigad from SOE, and you also have Clement Tam and many others, Professor Kumar Manikwel in that. And you have Fasika, Dr. Ferenc Kuhn, Gangadhar Sundar, and Dennis Lam in this is McCormick Place in Chicago, 2016. And then this is the Nepal Ophthalmic Society, and APOTS organized an ophthalmic trauma CME, 15 December 2015, 5 years back, with a slogan of preparing for future. And I'm glad we are 10 years old, and I'm glad we are celebrating the 10th anniversary today. And I'm glad in 2021 is going to be a great year. Hope we prevent ophthalmic trauma. And one of the homework of myself and Rupesh Agarwal is to stop public bursting of crackers, at least in India. We can talk of India as of now, and I'll work on it. And you can see Gangadhar Sundar, Carolyn Chi, and Victor, Dr. Rupesh Agarwal, and Professor Azad, President Emre. I'm glad every opportunity Gangadhar Sundar has, he hosts in Caroline, his house or Caroline Chi's house. And then we have this, and we have, we can see Dr. Quresh Musketi, his wife, Azad, Dr. Carolyn Chi, her husband, and Ganga, there's a real better half is there. Thanks to her. She always gives me wonderful food. Thank you, Ganga, for having me stay with you all the time. And this is just to catch up. Second APOTS in the Chinese Ocular Trauma Society in Dalian, China in 2015, and the first one in Shenzhen 2014. The APOTS postgraduate education of ophthalmic trauma, and APOTS in Hyderabad in India in AOS 2013. I thank the entire team of APOTS and especially Gangadhar Sundar for putting this excellent program and having 6 presidents. We have the president of EVRS, Giampaolo Guinea, President John Talma, President who's the fourth one? And Dr. Tamara Fountain, and then fifth one is who? EVRS, I said Giampaolo, then
Ryan.
who
Hello, hello.
Chinese.
Hello, Ganga.
And
Yes.
Ganga is a chair. And over to you,
Ganga.
Ganga. Over to you, Ganga.
Right. Thank you. So
Can you
I'm
hear me,
going to
Ganga?
share screen, and can you see my slide?
Yes,
Yeah.
yes, Ganga, we can see you. You can make
Yes.
it. Yeah.
So thank you very much for recapping the past 10 years. And 10 years now, looking back, seems like a long time. And thankfully, we've been quite active. Then we realized that when 2020, we had really looked forward to a beautiful meeting in Bali, where literally hundreds of people from around the world really signed up. And then what happened? COVID struck. And COVID struck, we were really stranded because we didn't know what to do with all the messaging of ophthalmic trauma that we wanted. And all countries in the world steadily and serially started going into lockdown. But there was still a hunger and demand for all the knowledge that we were sharing over a period of time, with experts like you traveling across the world, coming and sharing information. To me, the inspiration for doing all this has been Professor Ferenc Kuhn. I still call him the founding father of modern ophthalmic trauma management. He's devised a lot of things which the rest of the world has really adopted. Some parts of the world still is waiting to adopt. And what I like about him is always a patient-centric approach with novel concepts, and he has an interesting mix of conventional and unconventional techniques. And every time I meet with management or senior leadership anywhere, I always sometimes defy conventional wisdom, because that's what you want to put the patient first and deliver the best possible outcome. So we have been conducting various meetings, and we switched gears from the COVID lockdown periods, like Professor Natarajan was talking, with collaboration with Ocular Trauma Society, organizing the first ever APOTS virtual webinar, followed by the second meeting where we ended up having 6 different courses at the World Ophthalmology Congress. We've been working very closely with Professor Jan Talma, trying to really strike a relationship with our nations in the African continent, trying to start African Society of Ophthalmic Trauma. And we had wet labs design. Unfortunately, we had to go virtual, but it was quite successful. And then we went on to the third webinar, which is organized by the Giridhar Eye Institute in Cochin in India, where we are all now starting to learn how to do webinars and virtual conferences. And that interest really led to the 2-day first ever ophthalmic trauma webinar that we did in September, where we literally had speakers from all around the world. And interestingly enough, if you look over here, that's when we came up with the very first Global Perspectives Conference. That's when we really heard from different societies in different countries in the world, each one facing their own challenges and how they're willing to work together. Another aspect of this particular webinar was the first time we started involving allied health, ocularistry, low vision prevention, led by Annette Hoskin from Perth, Australia. And those 2 things were unique and really brought a lot of attention to ophthalmic trauma, not just in diagnosis and management by us, but prevention of ophthalmic trauma and rehabilitation as well. And Academy also went virtual, so we had a nice course. This is the 3rd or 4th year in running where we're doing an ophthalmic trauma course at the American Academy of Ophthalmology, and we'll be submitting one more course for this year. And APOTS has been involved in various other societies organizing various webinars. So this webinar was planned with the intent that 2021 will be a post-pandemic year, and we really wanted to learn lessons from different continents. We know that a lot of patients delayed healthcare, or because of the restrictions, there's a lot of suboptimal care. But creativity amongst the surgeons and hospitals have taught us how to overcome patient and patient care handles. And that's where global collaborations comes in. And I'm a strong believer of learning from each other. None of us are perfect. And that is what led to this particular webinar, and really thank all these esteemed speakers that were invited from around the world. Professor Huayan from China, Ginny Giampoli from EBRS, Professor Jan Talmar from South Africa, Hugo Ocampo from Colombia, representing the South American continent, and the young Gary Recolt from the United States. We're also pleased to have Dr. Victor sharing with us today a novel implant in the management of traumatic glaucoma. And finally, and most importantly, we are really, really honored to have Professor Tamara Fountain from Chicago waking up at 6 o'clock in the morning to give us the 10th anniversary oration on trauma, triage, and management. Welcome you all. And I'd like to say a big thank to our sponsor, AOI, and the Paul Glaucoma implant, which has been revolutionizing everything. Finally, we're going to end up with a little discussion by Professor Ferenc Cohen and Jose Dolma, Kendrick, and Rupesh Agarwal. Dr. Azad is unable to be here, but I welcome you all to this webinar. Thank you very much. With this, I'd like to invite Professor Huayan to give the first talk on ophthalmic trauma, the Chinese and Asia Pacific perspective, with introduction by Dr. Rupesh Agarwal.
Thank you, Professor Ganga. And it's my honor today to introduce my dear mentor, and if I can call him my friend as well, who has taught me a lot, and he never leave any opportunity to teach. And even in this conference, when he was very busy in Tianjin, he was teaching me, giving some of his skills. Before you can see Dr. Mohan Rajan and none other than Dr. Ganga standing beside him at this meeting. And we really very fondly remember this meeting in China. And this is the picture already shared by Professor Natarajan, where we have Caroline Chi and Annette Hoskin and Dr. Ganga with Professor Huayan. So he is the really, in sense, as we are talking about the 5 continents here. So the first continent to go, and can I have his video, please, Andres?
Sure.
Thank you. The first speaker to go today is from the Asian continent. Before it will be, the next one will be the European continent. But let's hear from our Asian continent, who is the president of Tianjin Medical University. Again, very well accomplished in the field of ophthalmic trauma, does not need any introduction. If we call Professor Ferenc Cohen as the father of modern ophthalmic trauma management, I think Professor Huayan and Dr. Natarajan, they themselves have taken the ophthalmic trauma management in Asia to a different level, and he has well published numerous books on ocular trauma and numerous publications, and those are countless, and is really very much committed, and one of the rare people who is so much committed to the management and the care of ophthalmic trauma. He is the president of Chinese Ocular Trauma Society, as already shared by Dr. Ganga and Dr. Natarajan, and he's been vice president of Asia Ophthalmic Trauma Society, Asia Pacific Ophthalmic Trauma Society from the very beginning, and been the guiding force and the mentor for a lot of us and all the residents and all the colleague ophthalmologists in China. Professor Huayan, your video.
Thank you so much.
Azar, Lukish, and everybody. Today I'm talking about the challenges in the primary and secondary ophthalmic trauma management in the COVID-19 area. So at the beginning of December in 2019, COVID-19 caused by 2019 novel coronavirus spread rapidly throughout the world. So at the beginning of 2020, the World Health Organization and COVID-19 was a public health emergency of national concern.
Can we increase the volume, Andreas?
Globally,
I think it's
at the end of 2020,
No.
there have been more than 18 million confirmed cases of COVID-19, and the represented is mapped by a blue color in almost 1.7 million deaths represented by the color in this map reported by the WHO. So the epidemic of COVID-19 in China has been gradually and effectively controlled, although occasionally for radic and small class of cases. And the multiple protections of some routine diagnoses in treatment have been carried out normally. So During the period of pandemic of COVID-19, we still have the ophthalmic emergency treatment, limited time surgery, and elective surgery. So this is the challenge. The current clinical observation and epidemiological studies show that the transmission of COVID-19 is mainly respiratory droplets and contact. Aerosol may also be one of the roots of virus transmission. People are generally susceptible to the disease, and there is a phenomenon of aggregation. Medical staffs have a greater risk of infection with treatment process. So for safe ophthalmic surgery and treatment, since the occurrence of COVID-19 with the activation of case treatment and the in-depth research, the Chinese National Health Commission has updated the clinical and epidemiological characters of the COVID-19 in time. So the latest diagnosis criteria in China include suspected cases and confirmed cases. So now I will introduce the outpatient and emergency screening, ophthalmic ward management, pre-operative preparation and intraoperative protection, post-operative management and post-application, so the safe surgery and treatment during the epidemic of COVID-19 in all hospitals. So for outpatient and emergency screening, all patients and their families need to wear face masks while entering the clinical area. Before treatment, the patients are checked with COVID-19, like temperature monitoring and the epidemiological investigation. The ophthalmologist in the ophthalmic diagnosis area should complete the ophthalmic examination and the first level protection. And the patients who have been diagnosed should be treated strictly with the third protection. And patients who need surgery should be checked according to the blood routine, CRP, chest CT, nucleic acid test, and the new coronavirus test antibody test. For outpatient and emergency screening, if there is any abnormality, consultation with the relative department is required and double expert consultation. So the department, like the infection department, respiratory department, and emergency medical department, will be initiated. If considered as a suspected COVID-19 patient transferred to the isolation ward, the retrovirus nucleic acid test is completed, and those who tested positive are currently dated to the designated hospital. If the virus nucleic acid test has not been completed, but urgently needs surgery, please consult with an expert in the already department and start the operation procedure of the suspected patient and confirm the operation in the negative pressure operating and return to the isolation ward of the operation and wait for the nucleic acid test result. Medical staffs enter the medical isolation ward for isolation, waiting for the patient to move to the acid test result. For ophthalmic ward management, there are isolation wards, buffer wards, and general wards in the ophthalmic ward. The medical staffs in the ward have first level protection, and only one family member is fixed to be accompanied during the hospitalization. Patients and their family members wear face masks throughout the hospitalization period and are not allowed to go out. If they have to go out, they must register. Patients and their families complete the nucleic acid test before admission. The patients are transferred from the isolation ward to the buffer ward, transferred to the general ward after the operation period, and the staffs of the department should provide all protection and elimination of the treatment and the environment regulation. For preoperative preparation and intraoperative protection, monitor temperature changes of the patient and accompanying family members before operation. If the patient is excluded from COVID-19, make surgery and local anesthesia in the hospital, and perform the operation in a laminar flow patient operating room. During the operation, the patient wears a face mask to cover the mouth, and post-operative operating room is disinfected according to the requirements of epidemic protection. If general anesthesia is necessary, before the multiple disciplinary consultation, the personnel involved in the operation should strictly adopt secondary level protection and be implemented in negative pressure operating to reduce the media exposure. Preoperative preparation and intraoperative protection for the suspected and confirmed patient of COVID-19, emergency surgical treatment is required due to the condition, and the level is set to class 3 phase. Transfer the patient by special channel, and the operation is performed in negative pressure operating room. Strictly control the number of people entering the operating room, and all items during the operation are supplied and delivered by outdoor monitoring nurses. And the indoor personnel are not allowed to go out well. Strict 3-level protection during the operation should be performed, like medical protective N95 masks, protective clothing, double layer latex gloves, goggles, protective visors, boot covers, and shoe covers. And this is possible protective operation sheet, and clothing to protect leakage are required. For post-operative management, for the patient who excluded COVID-19, the patient should return to the orthopedic ward after general anesthesia or local anesthesia. For the suspected patient, they are transferred to the isolation room after general or local anesthesia. Medical staff without exposure in the whole process of the operation can apply for exemption from medical isolation for 14 days. If there is no exposure, medical isolation will be carried out for 14 days. If there are fever or other discomfort symptoms during isolation period, they should seek medical treatment immediately. Medical staff should take off the possible protective clothing, shoe covers, like others, and put them into the double layer medical waste bag in the contaminated area, strict and hygiene. This is the post-operative management, including the surgical instrument, operating room environment, and stressing the disinfection intensity of the operating room after the operation. For post-operative patient management, medical staff perform the operation such as applying eye drops and replacing the auxiliary materials and the first level protection standard. Closely monitor the temperature of the patient and their families, as well as other clinical symptoms. Management of the accident of the hospitalization, like this one, such as after the patient is admitted to hospital, develops suspicious symptoms such as fever, which could not be explained by this condition, and immediately starts the identification and the diagnosis process of suspected illness. Review the epidemiological questionnaire, survey, blood routine therapy, and other blood routine examinations are improved. And the chest CT examination should be complete. The patient is transferred to ophthalmic isolation ward. Secondary level protection for all medical staffs and double expert consultation should be conducted. And if COVID-19 is excluded, the patient continues ophthalmic treatment, and if it is suspicious, make nucleic acid test and the specific IgM and IgG antibody again and transfer them to the isolation ward according to the special transfer. If the results are positive, we should be coordinating with the designated hospital for treatment. If the result is negative, come back to the ophthalmic single room with the observation and treatment. Thank you so much for all of you. Thank you so much for all my friends. This is my soccer game with all the ophthalmologists during the pandemic and COVID-19. In the annual meeting of Chinese Ophthalmology Society. Thank you so much.
Thank you, Professor Huayan. That is just fantastic. I think you have shown us not just the challenges, but how to really overcome and manage these patients optimally during this challenging period. And we have a lot to learn from you. One of the continents which is really affected right after Wuhan was affected was Europe and Italy, for example. And we still seem to be suffering from COVID crisis with resurgence in the European continent and especially the UK variant. To share the European perspective and the British perspective, we invite Dr. Ginny Giampolo, a good friend from EVRS, to share his experiences on the European perspective.
And
he will be introduced by Dr. Andres Rosello. Sorry.
No, I was in China in December when the COVID was going on, and in January in Singapore with Gangadhar, and in February in Jakarta. And Giampolo is a very old friend and president of the European Vitreoretinal Society.
Thank you. As Dr. Natarajan informed, he's also the vitreoretinal consultant at Western Sussex NHS University Trust at Sussex, United Kingdom. He's also a vitreoretinal consultant at San Marco Eye Center in Florence, Italy, the president of the European Vitreoretinal Society, the American Society of Retina Specialists Vice Liaison Officer for Europe, and a board member of the Italian Society of Ophthalmologists. Dr. Giampaolo Gini, the floor is yours. Thank you.
Thank you. Thank you very much. And again, a special thanks to the organizing committee. They're all good friends. Some are new friends, some are old friends. And I wish APOTS the very best. I'm very honored to be here today, and I believe that what APOTS is trying to do is leading the way into a new care of ocular trauma, and it should set the example for many other societies throughout the world. Now, Professor Hua has wonderfully illustrated many details of how to handle these patients. So I would just try to touch on some other aspects which are more typical of our continent, that is Europe, because I believe that we do have differences as well as similarities. The differences are obviously due to culture, they're due to geographics, and they're due to obviously also political and economic factors. So let's see what has been happening here. As you know, I work both in the UK as well as in Italy, so I have a lot of friends that have been good enough to share their experiences with me, and we have combined our experiences to give you this talk today. When this is a
Today,
controversial
the greatest risk
video.
of global catastrophe doesn't look like this. Instead, it looks like this. If anything kills over 10 million people,
Sorry, can you share your screen?
It's most likely
Yeah,
to be
sorry.
a highly infectious virus rather than.
Excuse me, Dr. Gini, you need to share your screen with the green button down below.
Oh, forgive me.
Don't worry.
I thought I had done that. Right, trying to get around to it. Okay, let's see. Can you see me now?
No, can't see you yet.
There you go.
Can you see it now?
Oh, we can see the banner, not the video yet.
That's not what we want, is it?
So, Professor, what you can do when you go to share screen, first of all, you select on your laptop whatever you want it, and it should be there on your screen, and then go to share screen option, because sometimes it will choose something else.
So right now I have shared my screen.
No, stop sharing now. First stop sharing and again reshare. So stop now.
Okay.
And then go to your desktop, whatever your presentation is or whatever video is that. Click it, and it should be there on the desktop there. And then again go to again go to share screen and then share that.
If you want to work in the background, we can move on to the next presentation and then we can come back to this.
It probably is best to do that. I don't want to take up anybody's time. So shall we do that?
Maybe if you hit the green button over there, it will go full screen. Top left of the video, click the green circle, and then play or reproducir.
It says that it says that I'm sharing, but it doesn't seem to be.
Don't worry. There you go.
There you go. Perfect.
Can you see it?
Now,
yep. Now you can.
Full screen.
Okay.
Play.
Is that it? We got
That's
it? Operational? Good. Okay, so this is a controversial video. Some people like this gentleman, some people don't.
Today, the greatest risk of global catastrophe doesn't look like this. Instead, it looks like this. If anything kills over 10 million people in the next few decades, it's most likely to be a highly infectious virus rather than a war. Not missiles, but microbes. Now,
so I think you heard those words from Bill Gates, who was a very controversial figure, but he certainly did say something interesting back in 2015, but he obviously did not have a particular insight apart from history. History has shown us that we have had a number of epidemics which have accompanied mankind throughout history. We all know about the Spanish flu, which killed a great number of people. Some say 80, some say 100 million. But from the beginning of mankind, there have been plagues of all sorts. From Justinian's plague, I was researching back in 540 after Christ, half of the world population was wiped out. The Black Plague in the 14th century took care of another third of the population of the world in those days, and we've had many other similar occurrences. So it's nothing new, and I would say that we've always dealt with epidemics in the same way, basically by distancing, by you can see the nurse here in the 1968 epidemic when hospitals were closed down. So I think that we have seen this happen before. Now, the World Health Organization was actually preparing for such an event, and it pointed out as the number of epidemics was growing throughout the world, how the world should prepare and more coordinated efforts should be made for state agencies to share data, prepare for an epidemic. unfortunately, this has not happened. And when the COVID virus hit in early 2020, the world was simply not prepared. So we know that on a timeline, we had obviously the first cases reported by China at the end of 2019, and then they hit Europe in the early months of 2020, and Italy in Europe was the first country and one of the first in the Western world to go on complete lockdown, and that was on March the 8th. After which the World Health Organization, after a few days, declared COVID as a global pandemic. The lockdown lasted in Europe until around June. There was some easing after during the summer months, and then again we hit a second wave, which is now climaxing, especially in the UK, which has come, as you know, to a lockdown. We are now in the highest possible tier level, which is tier number 5, which we'll talk about in a few minutes. So how did the epidemic actually, what effects did it have on the health system? Well, essentially, it created an unprecedented number of acutely ill patients. And this created capacity issues, not only in the intensive care units, but throughout the whole hospital system. So many departments were either converted to COVID units, or they actually could not carry out their normal work because of fears of contamination. And therefore, many standard procedures and much of the care, for example, for cancer patients, had to be postponed. And this obviously created huge problems. Also, many operating room procedures had to be stopped as a trained staff, such anesthetists, had to be diverted to intensive care units. So what did governments do? Well, the first thing that governments did was to progressively introduce restrictive measures so as to keep the hospitals from being overwhelmed. This was done in the UK with a tier system in which you see there essentially four different tier levels, where the fourth is a clearly declared epidemic and where people are asked to stay at home. The fifth level is actually more theoretical than practical. It is where we reach a level where we believe that the whole NHS, the national health system, can be overwhelmed. So in Italy, we have something similar. It's a color-coded system where we allow people to move with more or less freedom according to the color of the region in which they live. And of course, the all-important number nowadays has been the R number, on which we base all the decisions. So the R number being the number of people that can be infected by a single individual who was actually carrying the virus. Did these measures work? Yes, indeed they did. We can see that the lockdown and the infection rates in the UK dropped dramatically after the 24th of March, when the first lockdown was introduced. So no doubt that these measures are really effective in reducing contamination. But what effects did they have? Obviously, they had, as we would say, side effects. They had a profound impact on many, many aspects of life. And these went from the economy, which has suffered very heavily, to society and social behavior and problems related to that. But also the medical practice was obviously very, very highly affected by this lockdown. So specifically, when we talk about ocular trauma, it comes to my mind how lockdown and how these restrictions have affected it. And I would put it down in essentially in four main categories. One, as Professor Hua pointed out, the delay in patient treatment. Two, the different injury pattern which we now have experienced, and someone was just talking about this before we started this meeting. And three, the need to adapt hospital facilities and safeguard staff. And I think Professor Hua already mentioned how this is done in China. And finally, the need to maintain surgical skills. And I think Gary will be talking about this, because we must maintain our surgical skills, not only for ourselves, but also for the people that we have in training. So for some reason, okay. So the delay in treatment occurred because of two reasons, especially. One, the reluctance of patients to attend hospitals, which were thought to be unsafe. So if you ask people to stay home, people will be afraid of going to hospitals, and the media was responsible for some of this, I would say, misguided information. And then the rerouting of patients due to hospital capacity issues, which made accident and emergency departments dysfunctional, so that they could no longer treat minor traumas because they had eye traumas, because they had more important issues to deal with, or limited access to general anesthetic for severe cases, so that these patients could not be treated at the first hospital they were referred to, but had to be moved on to tertiary treatment centers. And this is an example which I put in. This is a young man that was doing some work in his house. He felt his eye being hit by something, didn't know what. As it turned out, it was a corneal perforating injury with this retained foreign body, which was detected only at the end of lockdown, so after several months. And you can think, obviously, of the risk which is involved with this, with the possibility of endophthalmitis, the possibility of siderosis, and all the different things that you know as well as I do. So why did this patient not come to A&E? He was afraid, obviously, to attend hospital. Looking ahead, because this is the title of my talk today, looking ahead, what can we do to avoid delay in treatment? Well, we can improve communication with the public. So the media should make it clear that that delaying the treatment in ocular trauma can have devastating results. And so people should be invited to attend hospitals, because we have learned our lessons in these past few months, and we have tried to make hospitals as safe as possible. Also, this can be done through school children. School children are always very receptive. They also influence their parents very much. And even with remote teaching, as we have now, because you know that our schools are closed, this message can be introduced to the children, and they will pass it on to their parents. More on this in a second. And then we can improve the coordination with primary care providers. These are the GPs, so family doctors, out-of-hours services, 111 in the UK, 118 in Italy, and so forth. And even opticians and pharmacists can all contribute to having the patient attend care when needed. Also, we can approach this by providing safer environmental conditions, which will make the patient safer and more at ease. So ideally, we should have independent, completely dedicated green ophthalmic structures. Now on the left is Western Sussex, where I work, and this is a completely dedicated ophthalmic hospital in line with the protocol, with the manifesto of the Royal College of Ophthalmologists, which calls for more independent centers even before the epidemic broke out, so that more specifically orientated ophthalmic services can be provided to an aging population. And of course, the third line of approach is that of using telemedicine to a greater extent to triage and counsel patients. Now, this can happen through primary care providers, but as Natarajan was telling us that they have 5G in India, as we get 5G and more advanced technology in Europe as well, we will probably be doing away with the intermediate primary care providers, and patients may address their ophthalmologist directly. Now, we have noticed, as I was saying, a different injury pattern. There has been a decrease in severe work-related injuries. There has been a decrease in pediatric injuries, although this applies to Europe. It does not apply to all parts of the world. I was reading some papers from India where they actually had an increase in pediatric injuries. There has been obviously a decrease in sports-related injuries, but again, I was hearing Professor Watt that was mentioning the fact that this is not always the case. And we have had an increase in do-it-yourself injuries because people have dedicated their time to home improvement and doing their hobbies. There has also been a slight increase in globe ruptures due to domestic falls, at least in our experience. And this may be due to mental health issues. People are tired, exhausted of being in the house all day, especially people living in apartments. I think they lose concentration, they lose a lack interest in everyday activities, they become careless. And interestingly enough, there has been an increase of about 25% in domestic violence throughout Europe. This applies to every country in Europe. The numbers are very similar. And you know, when you're living with somebody all day in close quarters, things can get pretty tight, and probably this results in something like this.
Because of coronavirus, you are going to be quarantined, but you have a choice. Do you A, quarantine with your wife and child, or B?
Yes, I totally share this view. And so looking ahead, what can we do? Well, we have regulations on the workplace. This, especially in Europe, they're very strict regulations. So the number of accidents on the workplace has diminished. Now we need to give education at home. So people should know that they must wear safety goggles. They should store chemicals, detergents, and so forth away from children. And this can be done, again, through the media and through children at school. Looking ahead, and I'm almost finished, there are challenges, and the challenges are those of protecting staff and protecting patients. Right now, what we have in place are molecular swabs for all patients accessing our operating theaters. They are usually delivered in 4 to 6 hours, and therefore we can deal with most emergencies with a reasonable degree of safety. When this is not possible, then we move up to full PPE with FFP3 masks and visors to protect our staff. We must also work on guaranteeing access to the operating room. And Gang, I was talking about this, how we need to actually work with and sometimes put pressure on the management so to underline the importance of ocular emergencies, which are not only retinal detachments, or obviously all sorts of emergencies which go from glaucoma to ocular trauma. And we must coordinate territorial resources so that more hospitals can cover a certain area and deliver, maybe coordinating the resources. Those services which cannot be given by one hospital can be given by another. I can only thank all the people that have contributed with their thoughts, with their statistics, with their experience. The members from EVRS, the members from the Italian Society of Medical Ophthalmologists, the British Emergency Eye Care Society, the Italian Vitreoretinal Society, and then my good friend Marco Pellegrini from Sant'Orsola Hospital in Bologna, who has published this interesting paper in Eye Changing Trends in Ocular Trauma. And this is a nice paper if you want to read it. It gives a snapshot of what is happening in Italian hospitals today. And of course, I want to thank all of you for putting up with me. Thank you.
Thank you, Giampaolo. And I think, as usual, very erudite presentation. And I think you covered the things happening. And I think everywhere this domestic trauma has happened. And I don't know whether you know, in India, unfortunately, the wives could not tolerate the husband. And then the wives have hit the husbands. And then I operated it's not a joke, I operated a husband whose eye was having a suprachoral hemorrhage and a tear, and the eye was no PL. And he came today, and then the wife is crying. Then I said, don't feel guilty. You hurt him, but now what to do? We have to do the surgery. So,
but actually, men tend not to report this because of obviously ancestral heritage. But there are websites where men can anonymously sign up and report domestic violence. So we always think of men on women, but it's no longer a gender issue. It's just now widespread violence. Yes.
we are sharing the screen, and actually, I'm going tomorrow to a place called Nashik, which is about 3 hours from Mumbai, and there is an association called Husband Battered Syndrome. Husband Battered.
Yes. Yeah.
Beaten up by the wives. Great presentation, Giampaolo, and I think thanks for an excellent thing happening in Europe between Italy and UK. Thank you very much.
Thank you.
And I think we are going to have the discussion later, right?
Yeah.
Yes. Okay. So, Kendrick, you can start.
Yep. Thank you, Professor Natarajan. So next, I'd like to introduce Dr. Talma. Dr. Talma is from South Africa, and you might remember him from the recent WOC 2020, where Dr. Talma was one of the specialty coordinators, particularly for ophthalmic trauma. Just to introduce Dr. Talma, so he's currently a consultant at the Pretoria Medical School, also chief consultant at the First Military Hospital. He's the president of the Ophthalmic Society in South Africa, and also the president of the Cataract and Refractive Surgery Society. He also was involved in a lot of charity. So he was a founder and trustee of the Right to Sight Charity Trust. And he is also founder of a number of businesses, including the Pretoria Eye Institute. He's also a director for the National Hospital Network. So today, Dr. Talma's talk will be on ophthalmic trauma and African perspective in terms of the challenges and opportunities. So thank you, Dr. Talma.
Thank you very much. If I may, I think, thank you for the opportunity. I think I'm delighted to be here, and thank you for this brilliant webinar. I think it's fantastic. My aim is a bit different than the COVID. In South Africa and Africa, we do more or less the same as all over the world. I think our trauma profile is slightly different. And maybe we can later discuss that. But our aim is just to explain a bit on a way if we want to create a trauma society for Africa. We have trauma is very common, but we do not have a society in Africa at all, as far as I know. And I think it will be a good idea how we can overcome the challenges. But before we do that, I think it's important to understand the dynamics of Africa and the challenges we all have in Africa. And if one understands that, it's easier to understand where we're going to. Financial disclosures, I've got none to declare. I think as background to ophthalmology service delivery, the realities of the African continent are very important. The current situation and future opportunities in terms of healthcare and trauma care. There are many factors, like in any country. In Africa, I think economical and social situation is a major factor. Disease burden, the management of healthcare systems, mostly by states. Human resources is a big factor. Logistics, and in the areas where there's private sector, we have corporatization and business ethics. Managed care like in the US, but a bit more to the extreme. And COVID is more on the economic effect than anything else. So I like just to repeat, I think some of you might have seen these slides, and this is the realities of the world we live in. And within these constraints, we as doctors have to function for good or for bad. It gives us hurdles, but it's also opportunities. If we look at national income, It's an important factor in healthcare and eventually our ability to deliver comprehensive care, also trauma care. If you look at violent deaths, and this is a bit different than the rest of the world, you see in Africa it's pretty high, and it's also related to dominant factors include efficiency of governments, management ability, corruption levels, and all other factors. Accidental deaths are slightly less, and they're a bit more in the area of India and China, according to the World Mapper. And if we look at all injury-related deaths, we see the indications are also more to Asia than in Africa as such. But let's look at incidence of trauma cases. We have two structures in Africa. Most countries, you have the state sector, the public sector with a mass of people, and a selective smaller private sector. In the state sector, 2.2% of new cases, 6% of outpatient clinics is trauma. So it's part of daily life. In the private sector, more like Europe, 0.14%, 0.7% in the private sector, which is probably what you experience. Major injuries are very common, and this is managed from a registrar level later on. But why do we need to look differently at trauma? Personally, I see this a patient I saw waiting time before surgery 2 weeks. And this is not because of COVID, this was just before COVID. And this is the type of dilemmas we have in our world where we're coming from. Blinding disease, this is more to glaucoma, cataract, and diabetes. But a big part of the dilemma is physicians working. And that's in general physicians working. And this from the British Journal of Ophthalmology, ophthalmologists in the world. And you see in Africa, we have at the lower end a very low number of ophthalmologists per million of the population. In the upper part, northern side of Africa, the stats and Asia, it looks much better. So that is the realities within which we work. Average worldwide, 31 ophthalmologists per million. Sub-Saharan Africa, we work on 2.8 million in English-speaking countries. French countries, 2.2 per million. Portuguese, 1.2 ophthalmologists per million. Worldwide, we know there are 14 countries with less than 1 ophthalmologist per million, 31 countries 1 and 3, and only 13 countries more than 100 per million. So 100-fold difference. And I think that's a challenge we have to live with. Population of Africa is 1.3 billion. There's guesstimates it might double in 30 years' time. And once again, we see the populations in some countries where we have pretty low number of ophthalmologists per million on the population. In our country, we have 6.3, Botswana 5.4, but the larger numbers are in private sector and less working in the state. But this sounds all doom and gloom, but in exchange, we have excellent surgical skills. If we see someone to start his residence and he hasn't done 100 or 200 cataract operations before he starts even his training, he won't be taken very serious. And during the training, practical surgery is done on a daily basis. So the scope is that anterior posterior segment surgical skills are trained to registrar. And when they complete their residency, they're pretty competent in it. And so trauma is managed usually by people who do the whole full spectrum of trauma. Anterior, posterior, even orbital trauma can be done often in one sitting. And this is the advantage and the luck we have on our side. For APOTS and other societies to talk to Africa is often difficult. There are societies in each country, which wasn't the case long ago. Under the ICO leadership, there's been 2 big groupings, the African Ophthalmology Council, which represents Sub-Saharan Africa, East, West, Central, Southern Africa. And then there's MIACO, North Africa, Middle East, Turkey, and even Iran. And these are 2 very well organized organizations, and that can be used as a vehicle to implement, as our chairman has said, what they want to do in future. But quickly, let's get back to basics again. In Africa, we must realize there are a lot of various healthcare models, but in essence, it's all the same. We have a state system and often a partly private sector. If we look in South Africa, we see 45 million government sector, 10 million private sector, 5 million both. The state sector is a combination of first, second, and third world level, private, first world sectors. And in general, we see the facilities, not necessarily the staffing, but the facilities are excellent in both sectors all over. And infrastructure and equipment is surprisingly good, even in remotest parts of Africa. And that's always a surprise when one visits these areas. In the private sector, doctors are available 24/7, surgical skills are excellent. State sector, pretty good, but the burden is massive. Cataract backlog, there's arguments on the level, but maybe 100 to 60,000 just in our country. Private sector, all the bells and whistles you can dream of, you can do what you like, and there is massive infrastructure and skills available. And neighboring Lesotho, even 3 operating beds in 1 theater works well, excellent work done by highly skilled surgeons in those areas. Anesthetics, usually not a problem. Anesthetic nurses are not common, and ophthalmologists often do local anesthetics. And then if we look just to highlight the contrast in our continent, and that's where we must think about. If we see the blue line, it's a bit confusing slide, but we see our private sector being rated by Monitor Studies as number 4 or 5 in the world in terms of access, cost, and quality. But the total of our country is pretty low because of the public sector where there's major problems. So if we look, that's why it's not surprising to see that the first lens was implanted, LASIK research done, first heart transplant in South Africa. But the moral of the story is, what do we do? What do we as professionals do for Africa? And that's my plea. Are we hanging around and see and wait? No. I think we must challenge the challenges and tackle the elephants in the room, which often is linked to politicians, governments, insurers, big business. And I think we as doctors must try and challenge those. If we do that with your help from the outside international community, we can do a lot, not only for trauma, but for all our patients. And in summary, for the whole of Africa, we have dual systems all over the place, mostly. The rich, small percentages, the poor, second, third world, and often driven by economic performance. The positive side, their skills are excellent, and the professionals are very skilled and very easy to handle complex cases. And the facilities are in general not bad. But on the negative side is that ophthalmologists, the numbers are very limited for patients. Trauma is delivered often by residents and junior staff with limited direct supervision. It's often delivered after hours and with the next day's surgery in the private sector sometimes, and in public sector with long waiting times and logistics. If we look at if you see in a country like Botswana, there are sometimes patients who have to travel 500 kilometers to get to a reasonable facility. Now this is for poor people, obviously a sentence on their vision in the long term. So what can we do? There are 2 segments, macro environment and micro environment. The macro environment probably lies with governments, dual systems, overwhelming workload, logistical problems. The micro environment, we can do something about. And that's to create, in our instance, awareness of the complexity of trauma cases. And this should be managed by the higher skills professionals, also over weekends and public holidays and Christmas. So obstructions in the referral systems. And these are the things that we must look at, I think, as ophthalmologists. What can APOTS and ISOT maybe do in Africa? Once again, macro environment, communicate with macro organizations like the African Ophthalmology Council, the Middle East African Council, and others. On the micro environment, awareness of the complexity. Interact with the societies, they're so keen, they all have congresses, and maybe offer to international speakers. And Ferris Keen has been fantastic He's nearly an honorary citizen of our country with all his visits, and he's done so much. Ferenc, thank you so much. And I think being involved in training at universities, and then let's start and create special interest societies, special interest groups. And I think that is maybe a way forward for the international community to help trauma in Africa, which is a major factor. And once again, these two organizations. So, Chair, I hope this gives you a very quick overview of what happens in Africa. There are societies in each country, and doctors are very keen, but maybe need some help and advice that you can offer us. Thank you very much.
Thank you very much, Dr. Talma. I'm always enlightened when I listen to you and really sharing the challenges, the successes that you faced. And I now know that South Africa is going through its own challenge now with the same COVID virus. And you were relating earlier on to alcohol playing a role, men playing a role, which is a common risk factor for trauma all around the world. And it'll be good to hear in the panel discussion, what are the things you've done to overcome some of these challenges. Thank you very much, Dr. Talma.
Pleasure. Thank you very much.
Can I make
Thank you, Dr. Talma.
Yes.
No, yesterday I saw a patient from Botswana in my clinic, and I told him, why not we start teleophthalmology, where I think there are optometrists more than the very few ophthalmologists in Botswana. So something like that, I think we can think. Maybe we'll discuss that in the panel.
Yes.
Right.
Pleasure.
So it's my honor now to introduce my good friend, Dr. Hugo Ocampo from Colombia, South America. We have not met physically, but we've interacted. We've done some talks for their ocular trauma series that he's been doing. And he and his team have taken the series of doing monthly education or weekly education over several months to really cover various aspects of ophthalmic trauma, involving speakers both from the South American continent and the rest of the world. And to introduce Dr. Hugo Ocampo, I have Professor Caroline Chi, our treasurer of APOTS, to say a few words.
Thank you, Danga. It's my great honor to introduce Professor Hugo Ocampo.
Caroline, we can't hear you.
Can you hear me now? Can you hear me?
Yeah, loud and clear.
Okay. It's my great honor to introduce Professor Hugo Ocampo, who is the professor in retina and ocular trauma of the Universidad de Valle in Cali, Colombia. He is also the former president of the Colombian Association of Retina and Vitreous and the former president of the Pan American Association of Ocular Trauma. We are looking forward to his talk, which is Ophthalmic Trauma, a Latin American perspective, strengths and weaknesses.
Hi, thank you very much, Dr. Okay, can you hear me?
Yes.
Okay, thank you very much for this kind invitation, especially to Ganga and Natarajan. And I'd like to share with you this presentation about ocular trauma in Latin America. Okay, I want to share about the bad, the good, and the ugly in our continent. This is Latin America. Latin America goes from Mexico to Patagonia in Argentina. And of course, I have many cases of ocular trauma. Fortunately, we have an association of ocular trauma, is APTO, is Pan American Association of Ocular Trauma, is APTO in Spanish. I like to show about the bad in our continent. The first is, of course, ocular trauma is one of the main causes of ocular trauma in our countries. Without COVID and with COVID, of course. This is a picture from me in my office with the fellow checking on patients with ocular trauma. And I'd like to show some statistics from some countries in Latin America. This is numbers for Guatemala in 1909. You can see in 1 year, 5,433 patients is main, almost 15 patients per day with ocular trauma before COVID. Chile, in between 2016 and 2019, almost 31 patients per day before COVID. After COVID, the numbers don't change a lot. 43 patients per day is only because it's the Jan to March, this statistic. In Colombia, here, before COVID, we have in this almost 1,000 patients, and the maybe 60% of legal blindness. And after COVID, here in Colombia, this is the register and our hospital in the Bay University. In 9 months, we have, February to October, maybe 1.1 case per day. In the statistics, the same, the majority is for male, and almost 20% is penetrating trauma in this moment, in 2020. So the balance before COVID and after COVID is almost the same here in Latin America, almost in three countries, okay? But this so difficult educates the population about the protection. This is a few numbers about the register of Latin America trauma, and you can see that 100% of the patients with ocular trauma don't use any protection in the moment of the trauma. We know the education is the most important part maybe in the management of many diseases, even in ocular trauma. What is the good things with us? I talk about the APTO. APTO is a child of Pepe Dalman. This is some of the people that work in ocular trauma in different countries, Chile, Guatemala, Ecuador, Peru, Argentina, Colombia, and of course, Mexico with Pepe Dalman. APTO, born in 1995, this is the original paper that Pepe wrote about his idea. And in this moment, we have 1, 2, 3, 4, 5, 6, 7, 9 presidents, and the next president will be Carlos Juan from Peru in this year, 2021. APTO has a mission is to educate the people in all continent. And the good is that we have the same ideas in ocular trauma management that Ferenc could teach for us. This is a very old picture, maybe 10 years ago. I was here, is Pepe, is Ferenc, maybe in American Academy of Ophthalmology. And the idea is to transmit the patient for the ocular trauma. This is Felipe Morera from Chile, and she is Dr. Wendy Reyes from Guatemala. The idea is to could transmit the patient, the managed trauma, about the ISOT ideas, up to could these ideas and transmit the same message. 2008, I made the first international ocular trauma in Cali, Colombia with Pepe and Ferenc. And Felipe Morera is one of the most enthusiastic doctors in this moment in Latin America in the ocular trauma field. Felipe made the first Latin American meeting in ocular trauma in Chile in July the last year. But after COVID go all the world. But again, Felipe Morera organized a beautiful online meeting, was pole to pole, the Polo Apollo, in June the last year. And again, we could to show, to teach of many people around the world with the magic of internet, the ocular trauma management. This is the picture of the all people that work in ocular trauma. And recently, we organized a beautiful ocular trauma course. The idea was made maybe 100, 200 people in this ocular trauma, but was a beautiful experience because we count shared to 20 countries, 21 countries and 37 speakers around the world. And we made this course every Saturday at the morning Colombian time for 3 months. We could have in average 5,000 people, even 8,000 people on Saturday in this ocular trauma course. So we created an application for ocular trauma management. This application has the OTS app. What is the idea of the OTS app? Is just translate the OTS, the beautiful tool that friends create for some time, 2009 maybe. And if people that has this application could calculate the OTS and can find the people that work in ocular trauma, the closer place that the practitioner or the general doctor use this application. What is the idea with APTO? Is teach the proper trauma ocular management to colleagues in Latin America. This is the kind of surgery that we teach in our meetings, is try to do the surgery on time. And this is one of the cases that you usually do from Mexico to Patagonia, is do the surgery in just one time, or at least teach the people to close the eye in the best way and teach the signs of alarm. That's, for example, this chemosis that showed penetrating ocular trauma. And this is the kind of story that I try to teach to our doctors in Latin America. Okay. What is the ugly? Of course, I know that we have extensive experience in ocular trauma management in Latin America, but we publish very little, and we don't have the culture to publish so frequently. And moreover, it's so difficult to obtain a budget to investigate in our country because we have another needs, and maybe the possibility of obtaining budgets is very difficult. However, you know that what is published doesn't exist. So we need to try to publish more, but we need more budget to obtain that. However, we have many good things. For example, in Chile, the state Chile covers up 100% of severe trauma in many cases. Guatemala, with Wendy Reyes, create an exclusive clinic for the management of ocular trauma. In this moment for the pandemic, this clinic of ocular trauma is closed, but we hope that maybe reopen. Mexico, Pepe Dalma recently created an eye trauma clinic with the same idea of Wendy in Guatemala. Here in Colombia, in January 15, I mean the next week, we will start the Retina and Ocular Trauma Fellow. It's 18 months of training of ocular trauma. And APTO created recently the PETIT. Who is PETIT? Sorry. PETIT is the Pan American Eye Trauma Investigation Team. We want to work more in publication, in investigation, to share with the rest of the world the kind of management that we offer here in Latin America. So I think the 2020 or 2021 is probably very likely to be the same as 2020 in terms of pandemics. In this year, last year in 2020, we learned to use virtuality as a very good tool. The distance were abolished. And I think that we can work as a single global ocular trauma group with these tools. Okay, this is my family. You see a place called Chia in Colombia, and of course with Max. I want to say thanks again to Ganga, to Natarajan, and the all people who thank you very much.
Thank you, my friend. I think you're doing a lot of work in South America, and I think every time when I was invited to Bogota somewhere, I got stuck. I hope, I think 2-3 years back also I was invited to Cartagena, and I'm still yet to come. And I think all the invitations are postponed. I don't know when to come. One day I'll come. But I think wonderful. Your petit program looks wonderful. Let me know how we can actively take part with you from this part of the world. And now I invite Gary. So I think Dr. Rupesh will introduce Gary.
Thanks, Professor Natarajan. And we'll now move to North America. And we have my dear friend Gary from US, and he represents the US Army, and where I was introduced to him through Grant Justine and my dear friend Marcus Collier. He's working currently at Brooke Army Medical Center, San Antonio, Texas, USA. And very interestingly, he's a residency program director, and that's what we want to hear from him for the SOSTEC ophthalmology. And he's also the president of Society of Military Ophthalmologists, and he's assistant professor at Uniformed Services University. Most importantly, he's a refractive surgeon, but with a lot of passion and a lot of interest in trauma management and particularly teaching the residents. To present to you is Gary. Gary, over to you.
Thank you so much. It's an honor to be here, and I thank you guys for your time and letting me speak to you today. So we've talked a lot about different challenges out there, and I just want to emphasize on how to teach people. How do we get through these challenges? And my job is to help our residents. So we're going to talk about resident training in ophthalmic trauma and how do we overcome these challenges in this current era. So thank you very much for your time. These are my views and not those of the Department of the Defense or the Army or the US government. I have no financial disclosures, neither does my spouse. So first of all, thank you for teaching residents. It can be a thankless job at times, but it is very rewarding. So for all those that teach, thank you. I think most of the group, you guys are all professors. Thank you for teaching and taking that time to teach. So just a little bit about my program here in San Antonio, Texas. We're a city of about 2.3 million people. We take care of about half the city's trauma. We're the only level 1 trauma center in the Department of Defense. And so we are here to take care of the trauma of civilians. Even though we're a military place, we take care of a lot of the civilians. So I have 18 residents. I have 20 faculty that all cover trauma and have to be ready to deploy across the world to cover trauma where needed. We also train residents from other residency programs in trauma that are in military programs. And then we train our staff ophthalmologists have to be ready to manage trauma as well. So when someone is called up to deploy somewhere else, they'll often come to our facility to prepare so that they are comfortable with trauma. So if you've seen the news, you've seen lots of challenges in our country. We're not going to focus on these challenges, but let's focus on the challenges of how do we train people. All right. So one of the biggest challenges is finding time. How do we make that time? A lot of our universities and facilities want you out of the op at a certain time. There's a push to get through a number of cases. And so a lot of the ocular trauma cases take a long time. And when you're training, it takes even longer. So how do you make that available for the residents to give them that time to learn? Also in their schedules are very busy. So how do I create time for them to learn, to practice on the simulators, to practice throwing sutures? It can be challenging because we have so many priorities in life. So just to focus on the time so that you learn ophthalmic trauma. Another challenge a little bit is having patience. Sometimes it's so much easier just to take over and perform the surgery yourself. How often have you watched someone throw a suture and then you just have to cut it out and throw a new suture? I just think back of when I was a resident and my staff let me take time to throw the suture and then they took it out and fixed it, but they were patient with me. So sometimes it's tough when teaching sometimes, but you have to have patience. Everyone learns at different levels. Some people faster than others as they learn. Another challenge is having the experts. How are you keeping up with your skills to teach? We all don't have Dr. Kuhn in our program. In the military, a lot of us spend a few years in the military and then move on to civilian programs. And so we have a hard time keeping some of the senior experts. I remember 6 months out of my training, I was told I was one of the senior cornea guys. And so it was definitely a challenge to step up and be ready, but to have the expertise. Also during our training, during some of our fellowships, we don't throw as many sutures as we used to. A lot of our surgeries are sutureless. So when it comes to ophthalmic trauma, how are your suturing skills? How do we make sure we have that expertise? Then there's the case volume. You got to have the cases. If you want to be good at something, you have to practice. And so in the US, our residency is 3 years, and all you have to get for the globe trauma minimum is 4 cases. So are you the expert after 4 cases of fixing an open globe? Obviously not. You definitely need more practice, but that's what the requirement is from the ACGME. Now, on average, most programs, national average in the US based on last year's study, results was 9 open globes. So most residents graduate with 9 open globes. Our program, it was 9.5. We had the lowest resident had 5 and the highest had 17. So we have to figure out ways where we continue to get the case volume. I think in other countries, you have a lot more cases than us. And especially as we advocate to prevent ocular trauma, we're decreasing our business in the operating room, which is okay, but we still have to keep our skills up. Then we are also limited here in the US by our duty hours. Our residents can only work so many hours, 80-hour work weeks. We need to give them 8 hours between the shifts at times. So trying to manage their fatigue to keep them motivated and keep them going with their cases. So work hours can be a limit. And then funding. I'm a refractive surgeon. In refractive surgery, we can always find funding. Industry is very supportive. But when it comes to ocular trauma, it can be a challenge to get funding. Funding to help with training, to help with the patient care. But you want to have funding for these resources and these courses. I'll talk to you about a course that we hold. And we have to get funding to send our residents to these courses. So it can be a challenge to get funding to help with ocular trauma. And I've heard that from other countries as well here. And then staying motivated, motivation to take care of ocular trauma. You guys are all motivated. You motivate me to continue with ocular trauma, but not everyone's excited about ocular trauma. These patients come in after hours. You're up late. They can be very challenging cases. It's not the easy 5-minute phaco. You may spend hours, and these patients need some extra help. So how do you stay motivated to care for these challenging patients? And so it can be a challenge with our residents about halfway through the year after they've seen their 200th orbital fracture. They're not too excited to go see another one, but we continue to try to motivate them and keep them engaged. All right, and then with ophthalmic trauma, we have some unique challenges. We have this patient population that's sometimes not always the most compliant. Here in the US is often sometimes uninsured. We may not get reimbursed. A little bit more challenging when they're coming in after hours. Again, supervision can be a challenge as we teach ophthalmic trauma because it's after hours. So our first years are always seeing the trauma. Their seniors are available for backup. For our first 3 months of residency, we require the seniors to come in. But how often is the staff coming in to supervise? The staff come in for every surgery in our program, which is nice. But sometimes the residents try to do things on their own or don't call when they need help. So we're always working on supervision. Every trauma can be unique, and so they're very unique cases. So how do you give an algorithm in trauma? We're working on checklists and ways to do that, but how do we guide them through trauma? We just need to teach them the basic principles, but each case is going to be unique. And then safety, protecting our residents. One of the safety issues we've had is that we didn't have an ophthalmology room in the ER, and so they'd always want to come to our clinic, which is a long ways away from the ER in our hospital. And at night, the residents by themselves with the patient has a seizure or they need help or they feel uncomfortable around the patient. There was little, and so we've had to create a room in the ER itself to allow them to see these patients, although it doesn't have all our equipment and imaging systems. So sometimes their exams can be limited. And then one of the big things with trauma is the transition in care. And so you stay up all night, take care of these patients. How do you pass it off to your colleagues the next day? How do you make sure things aren't missed? And so we've been very fortunate with COVID. We've created a virtual sign out. So every morning at 6:45, our residents log in virtually through Microsoft Teams. And in the past, the residents all did a lot of this on their own, but now the staff is able to virtually log in and listen into it. So it really helps having the staff there at the sign out every day. And so we can kind of keep up, make sure we're not missing anything as we work together as a team to help with ophthalmic trauma. So to make sure that residents know what they're doing, they have to be able to perceive they're comfortable, and we definitely need objective ways to see how they're doing. One of the subjective ways we wanted to check, and Dr. Loretta at Wilmer and her team, they surveyed all the ophthalmology residents in the US. They got 118 responses to see what kind of made them feel comfortable or prepared for ophthalmic trauma. And hands down, it was the supervised and independent lab practice on animal or synthetic eyes. So it's really just getting that practice, supervised or independent. They just need to be working on the simulated eyes and the animal models to get better. Now, obviously, if they're doing cases, that's even the best way to do it, but our case volume is limited. So how do we teach ophthalmic trauma? And these are a few things that we continue to work with our residency to teach. There's lots of resources out there, but we need to get better with our texts, our videos, our online modules. We'll talk about some meetings we've had, simulation, and then I'm going to talk about our ocular trauma course. Is one of the things we're proud of in the military that we've been put on for over 10 years that really helps kind of teach the fundamentals of ophthalmic trauma, and then partnering with some of our trauma centers. So resources, texts, and videos. Dr. Kuhn's got a few books out there. These are expensive to purchase for every resident. We do try to get one for the program, but trying to put out videos are extremely helpful nowadays. When you're learning cataracts, everyone goes to the cataract coach and watches videos. We want to create that with trauma videos, and AAO has it with some of their online OneNet videos, a really good one for Open Globe. But we hope with ASOT, our American Society of Ophthalmic Trauma, to continue to create videos, and I appreciate hearing all the efforts the different organizations across the world have done. Those videos, I think, make a huge difference to see your techniques and watch, and then continue just to create online modules. We had our meetings with COVID. It's better to meet in person, and we learned so much getting together. We create those relationships and we can create ideas, but that went away with COVID. We were fortunate to work with APOTS and the ASOT, and we came together and created this opportunity for residents to present their research and have discussion. And it was amazing, the research that was presented back in June. And we had over 150 abstracts submitted to my email, and it was hard to pick the top ones for this, but it was amazing to see the interest. And so it's great to continue to see the resident research, and we just have to be able to get together to share our lessons and work together. And then the big thing is simulation. We need to figure out ways to simulate ophthalmic trauma to prepare our skills before we're actually operating on a patient. So many residency programs have created kind of rooms for simulation, and this is kind of our efforts. We've done that at our facility. I've been to various facilities. I visited Iowa and Nebraska. They're getting grants from patients and working on simulation areas. And then they put time in the residency schedule for the residents to work with the staff to work on this simulator. Now, most of it's based on cataract surgery when you look at these centers, but we need to work on getting better models for trauma. How do we incorporate those into our simulate centers? It does all cost money, so funding can be an issue. How do you allocate the instruments and purchase the models can be a challenge. But simulation, what's out there? A lot of this, again, is based on cataracts, but how do we modify it so that it can help with ocular trauma? Some of the models that we have at the Boynico, it's very reasonable fidelity, and it's somewhat cost effective, but it is interesting. We've used this for kind of corneal lacerations, scleral lacerations. You can get ones with the muscle, and you can disinsert and reattach the muscles, the ocular muscles. So some of these models are very helpful as we practice and teach the techniques and just walk them through it before their surgery. The Cataro kits are good for cataract surgery, and glaucoma a little bit, but need to modify it a little bit more for trauma, and it's a little bit more challenging. Most of the residencies in the US have the IC simulator. We require a lot of modules to be completed prior to cataract surgery, but for trauma, it lacks some of the trauma benefits. But if you learn to be a good intraocular surgery and learn those basic techniques, work on avoiding any kind of tremors and just moving around in the eye, that will prepare you for some ophthalmic trauma. And so being on this simulator, we've noticed a huge improvement if the residents spend hours on the simulator, which we've had them do during COVID when they had downtime to prepare for being back in the operating room. And then one of the simulators, I don't think it's on the market yet, but we worked on at our trauma lab, was the ocular and cranial trauma treatment training system. And it's a nice model that actually gives you a score and evaluates you. It's a little nerve-wracking because you're compared to the residents and staff, but on the computer, it looks at your movements, it looks at your suture passes as you go through this tissue. It's not perfect to human tissue, it is pretty good texture. And so this is one of the example of a module that we could use in the future. Another one, lateral canthotomy, cantholisis, very important with orbital compartment syndrome. We use this to try to teach our trauma surgeons, our ER docs, but also our residents to make sure they know the steps so they're ready to perform their lateral canthotomy, cantholisis. The big thing that we've had for over 10 years, and we do this in Bethesda, Maryland every May, except for last year, we missed it in 2020 due to COVID, canceling everything, but is our tri-service ocular trauma surgery lab. And we put this on, and it's just to teach the fundamentals of trauma. And what it is it's a 4-day course where we work with residents and faculty to go over the basics and fundamentals, but also give them practice on our animal models that we bring in. We have lectures, many lectures about trauma and the different techniques, teaching the fundamentals. And then we have wet labs throughout the week. We used to do all the lectures first and then switch to wet labs, but we've now had it where we kind of give some lectures, mix in the wet labs. And it's a lot of one-on-one, almost two-on-one training with our residents. In 2018, we had 36 residents and 60 faculty. So the faculty are kind of wandering around, making sure we're one-on-one as the residents learn each suture technique. We walk them through the basics of just a single interrupted versus various techniques with the sutures. And so we work closely and monitor them as they go through that course. And so this has been huge. We try to send our staff before they deploy too. And we've now made it an Army requirement to go to this course for ophthalmologists. Within 3 years, they need to spend the week at this course just so that they keep up with their trauma. Other things we're working on is trying to partner with civilian institutes that have trauma centers. The Army general surgeons have kind of trained in the past, or they have a spot at the University of Miami. And so they go there and that's their assignment. They're paid by the Army, but they work for the University of Miami. And so we're looking at other civilian military partnerships right now, and Vanderbilt is one of them. But we're basically free labor. You guys have us for free. The Army pays our salary. And our benefit is we get to perform surgery and improve our skills and share our techniques. Now, COVID has caused some challenges. We've heard that from everybody. And so we're probably tired of it. But things that affects our training is our faculty and residents are tasked to do other duties. And this is across the US. The Columbia residents were on the wards helping out with kind of duties. Our residents have been fortunate and protected, but our faculty have been pulled to run the COVID tent, screening tent, testing people. Next month, I'll be spending a week giving out vaccines. And so my job is to take care of those with the vaccines. And so it takes you away from teaching the residents. We have to do what we can to help out. Bed space is a problem. Our trauma patients often I need to be put in the overnight. We watch them. Sometimes it's social admits, meaning they have nowhere to go and we just need to watch them. But now with COVID, we're trying to get the patients out the door and our beds are full here in San Antonio. We're struggling with that right now. And then COVID patients, as we talked about, using the proper PE, protecting our residents and staff. At times they're scared to kind of come in and see those patients. And so we have to make them feel safe to want to see these patients, and we have to teach them the proper way to use their protective gear. One of the things we used in the beginning, Columbia created this and put this on iWiki, is the triage guidelines, trying to help the residents of what they need to see immediately and what maybe can wait. But the biggest thing is to talk to their staff and see what they can do. Obviously, with ophthalmic trauma, it's more urgent and they should be seeing those patients. Another protocol, we've been trying to create protocols to help the residents so they're not up all night. So this is the San Antonio orbital fracture algorithm we call SOFA, to kind of help them guide through their training. So you can see that here, and we verified that this algorithm caught all of we didn't miss any vision loss due to it. We tested it out, but it shows some signs of when they should see their orbital fractures. And then teleophthalmology, I think that's the key of the future for some of this trauma. It's important in the military. We have a grant, we have called the Foxtrot app that we use for virtual ophthalmology, and we want to incorporate this into our training. So we really want the residents to start using this. Our goal right now is the ER to consult the resident virtually through teleophthalmology, and then the patient come back in the morning and we verify if anything was missed to see what we can and perform over teleophthalmology. So just in summary, skills can atrophy after residency, so we still have to continue to learn and train. Some people have lack of interest as they're in private practice and they don't want to be up all night, but you guys can make a difference. You do make a difference. So please continue to serve as a role model. Dr. Mazzoli is one of mine with ophthalmic trauma and one of our heroes. and continue to produce ophthalmic trauma teaching materials, videos, training modules, simulators, continue to support APOTS and ASOT. We started the American Society of Ophthalmic Trauma, and we hope to continue to grow just so that we can educate others and make a difference. So again, stay motivated. This is our residents. To stay motivated, they created a half marathon, and many of them were doing the half marathon for the first time back in November. But it was something for them to train for, something for them to do during these challenging times. So thank you again for everyone and your time.
Thank you very much, Gary. I'm so happy that Dr. Bob Mazzoli and Marcus Collier introduced you to us. And it seems like you accomplished a lot, and we have a lot to learn from. And I think this global collaboration is now going to flatten the world, and hopefully we will all learn from each other and come up with a structured course. We now, before we move on to the oration, we now have a message from the sponsor in the form of Professor Victor Ko, our head of the Department of Ophthalmology, who's going to share with us a new device which has entered the market, which has helped us manage traumatic glaucoma. Before we move on to the oration, we're going to have Dr. Manitosh Ray to introduce him for us.
Thanks, Dr. Ganga. So I'm delighted to introduce the next speaker, Associate Professor Victor Ko. Victor is currently head of the Department of Ophthalmology at the National University Hospital, Singapore. Concurrently, he is also the head of the Yong Lulin School of the Medicine at National University of Singapore. In fact, Victor had just started his journey as head just a week ago, in fact. Victor's primary area of expertise is glaucoma, both adult and childhood glaucoma. He is extremely passionate about the translational medicine, including the novel medical technologies. He has done his master's in innovation. He has been awarded with multiple translational grants at the national level. In fact, Victor is currently leading one of the summit program. We call it a SPIN program, which is a flagship program for the translational innovation at the National University of Health System. His main research interest remains in disruptive, innovative medical devices designed for the community-based ophthalmic diagnostics, as well as the new lasers and the implants for the refractory glaucoma. He has published extensively and served as reviewers in multiple peer-reviewed journals. So without much ado, I would like to invite Dr. Victor Ko for the next talk. Over to you, Victor.
Thank you very much, Dr. Ray. Good evening from Singapore, ladies and gentlemen. I thank the organizers for this wonderful opportunity to speak. I will just take 5 minutes of your time just to introduce you to the new Pore glaucoma implant, which was developed for refractory glaucoma. I have no financial disclosures to declare. There are many indications for glaucoma tube shunts, which generally includes conditions that predispose the eye to strong scarring response, such as failed trabeculectomies, secondary glaucoma, as you can see some of the examples in this slide. We will focus a little bit more on traumatic glaucoma, and tube shunts are very useful in this case because these eyes may need complex combined intraocular surgeries, or previous surgeries may increase the risk of conjunctival scarring in this particular subgroup of eyes. This is how the proposed new tube shunt looks like, the Pore glaucoma implant on the PGI. There are two main components, basically the tube and the plate, which has been designed and optimized based on the fluid flow studies that we have done in NUS. The plate sits in the subconjunctival space at least 8 to 10 millimeters from the limbus, and the tube will then shunt aqueous from the anterior chamber to the subconjunctival space at the equator. This table here compares the dimensions of the RMAT glaucoma valve and the Barvelt tube, which some of you may be more familiar with, and the newer PGI to your right-hand corner. It has a plate size that is bigger than the RMAT glaucoma valve, but smaller than the Barvelt, and it has an effective surface area that is optimized to increase the effectiveness of this type of tube shunt. It helps to reduce myofibroblast proliferation and bleb encapsulation. It has a shorter wingspan that also allows this implant to be implanted easily compared to the Barvelt. The tube itself is also something special. It has a smaller external diameter, which theoretically reduces the risk of conjunctival tube erosion as well as corneal endothelial damage. The smaller internal tube diameter, which is about half the size of the RMAT or the Barvelt, also help to prevent early post-operative hypotony. I would like to now show a very short video that has been heavily edited of the surgical implant of PGI. As usual, the selected quadrant undergoes standard conjunctival dissection. This segment here shows the patented stability system that we use in Singapore. We use a biological sandwich concept to modulate wound healing. The AC entry is done either with a 27 or 25 gauge needle, and then we use subsequently a cross-link viscoelastic gel over the plate as part of the stability system. The conjunctiva is then closed as per standard procedure. This slide here shows the profile of the PGI, which you can see with a smaller external tube diameter. We can see that using just a shallow scleral groove on the sclera, we are able to hide the PGI and sit it almost flush to the scleral plane. Now, in contrast, if you see here, the AMAT or the Barveld tube has a larger tube diameter that causes a prominent protrusion of the tube above the scleral plane. We hypothesize that this makes the tube prone to micro movement and conjunctival erosion. Now, on the same topic with a smaller tube diameter, the PGI is able to fit into narrow anterior chambers, which are more prominent in Asian eyes. And this also means that there's a higher chance that it's placed further away from the corneal endothelial layer to reduce corneal endothelial layer damage. We are rather successful and lucky to conduct a multi-center study between 2018 and 2020, just before COVID hits us. We were able to finish analyzing the 1-year data, and we published that mid last year in ophthalmology glaucoma. Amongst all the included eyes, n equal to 78, there were about 4 eyes with traumatic glaucoma. And in this particular table here, we try to summarize these 4 eyes that were included in a particular study. You can see that they all presented with very high intraocular pressure, with mixed mechanisms of related to directly or indirectly related to trauma, and they subsequently underwent PGI implantation. In the bottom row here, you can see that quite a substantial number of these patients also require combined lens surgery as well. This figure here summarizes the intraocular pressure trend, starting from a very high pre-op intraocular pressure, high IOP, to a very stable and lowish IOP at 1 month, 3 months, 6 months, and 12 months subsequently, with a mean intraocular pressure at about 12 months of 14 millimeters mercury. You can also see that concurrently there is a reduction in the number of medications that this patient require, with a mean of about 0.3 number of eye drops at 12 months. In conclusion, glaucoma tube shunt surgery is something quite useful and safe for intraocular pressure control of eyes with traumatic glaucoma. Now, frequently in Singapore, I perform the tube surgery in combination with lens injury. I'm not quite sure if you're aware of that, but in Singapore, one of the top cause of globe trauma, one of the top cause of sports-related eye injury is badminton. And this is where the shuttlecock comes in, hit the eye at very high speed, causes blunt trauma, and the lens in many of these cases gets damaged, cataractous, and it gets subluxed. So this is something that we can use apart from cataract surgery and lens surgery. We can also put in a tube for control of intraocular pressure. We should understand the limitations of current tube shunt design, and this is key to surgical innovation in this particular space. And lastly, I hope that with more and more data, we can show that the PGI is an effective and safe glaucoma tube shunt for refractory or even traumatic glaucoma. With that, I would like to thank you for your attention. These are my colleagues in NUH, where I work together with. In particular, I would like to thank my mentor, Professor Paul Chu, who is the inventor of the PGI and was given opportunity, and he has given me the opportunity to be the PI for the first in-man trial in Singapore, and subsequently the PI for the multi-center study. I also like to acknowledge Marcus Tan, who is my younger collaborator, younger colleague in NUH, who has provided materials for these slides. Thank you very much.
Thank you, Victor. I really appreciate a great scientific presentation. And we now move on to the highlight of our webinar, a grand show today, because we have the most illustrious ophthalmologist in the world, may I say that, Dr. Tamara Fountain, who had very kindly and graciously accepted to give the oration on occasion of the 10th anniversary of Asia Pacific Ophthalmic Trauma Society. When I approached her the very first time a few months ago, her immediate response is, yes, let me put something together and let's work together itself. She is a professor of ophthalmology at the Rush University Medical Center in Chicago, Most importantly, from an oculoplastic surgeon, extremely proud to say that it's a fellow oculoplastic surgeon who has an accomplished track record of clinical research, education, publications, and most importantly, leadership. Was a past president of the American Society of Ophthalmic Plastic Reconstructive Surgery, and going on to helm the leadership of the American Academy of Ophthalmology, the society that we all aspire to become members. We became members years ago. We've been looking to for training and education and quality and standard and so on and so forth, that she's achieved the pinnacle. So I'd like to introduce Dr. Tamara. Initially started off as a friendship over the years, but she has been extremely supportive for our education. And this is a picture on the left from our 30th anniversary at NUH in 2016. And she flew all the way and shared her time and expertise. That's when I was really influenced by her personality in addition to her scientific contributions. And of course, last year, the 50th year of the ASOPRIS evening, Dr. David Reifler and Dr. Tamara Fountain. What I admire more about her is not just the present personality. Most of us are physicians who aim to be healers, and most of us start off as simple ophthalmologists. But she then went on to become an accomplished ophthalmic plastic reconstructive surgeon, and now with ophthalmic trauma becoming an important aspect of ophthalmology, which has unfortunately been neglected for decades past, when Ferenc Kuhn really woke us all up to better management, better diagnosis. This physician has transformed herself from an ophthalmologist, a physician, to a physician leader and risen to the highest level. So I give you Professor Tamara Fountain on behalf of Professor Natarajan and Dr. Azad and the entire APOTS team. We'd like to present Dr. Tamara Fountain the oration, the certification, which will be mailed out to her, and the medal on behalf of APOTS, and give you Professor Tamara Fountain. Dr. Natarajan, if you'd like to say a few words.
Heartiest congratulations, Tamara. And we are very happy to have you. And a nice, I saw the old picture which you have taken in 15-16, and I'm glad you are here. And on behalf of Asia Pacific Ophthalmic Trauma Society, we are really proud that Asia Pacific Ophthalmic Trauma Society will work with the entire world, with Ferenc Kuhn as president of International Society of Ocular Trauma, with yourself as the president of American Academy of Ophthalmology, when you have 4 more presidents in this group. So I'm happy you're going to speak on trauma, triage, and treatment. And as he said, you're a physician healer and a physician leader. And I'm happy that you're also, I think, from the leadership development program from academy where even I come from. So I'm happy that we are going to work together. With this, I think we will mail you the, we are proud, we already signed it. We have sent you virtually, but I think we'll send it physically also. We wanted to surprise you, but it's early morning in Chicago. We couldn't get a person to come and give you that early morning in this cold weather. And I hope with the warm greetings, you will feel warm and give us the wonderful oration. Thank you.
What a wonderful introduction. I really, truly wish we could all be together. And Ganga, it was about 10, maybe 11 years ago, we were at the Miyako meeting in Dubai, and we struck up a conversation. We happened to be staying at the same hotel. And that was the beginning of a very rich friendship that's brought, I mean, I see so many people on this call that I know and have met across the continent. So I'm looking forward, like everybody else, to being in person when we can convene and when we can hug. And it's such an honor to be with you this morning. And Ganga asked me to summarize the American experience of ocular trauma. So over the next few minutes, I'm going to try to do that. Why is this important? I think we've heard some excellent speakers over the last couple of hours from all walks of life and all corners of the world. Ocular trauma is a major issue, and it's a major source of ophthalmic impairment. We have thousands of Americans suffering from trauma each year. And more importantly, the outcomes are often quite poor, with almost a third of people having final best corrected vision of less than 2200. When I thought about America and trauma, it made me realize that how you define trauma really is impacted by where you are. And I really was intrigued by Dr. Talma's presentation and how he really so graphically illustrated the differences in the continents, in how what kind of trauma we see and how we cover the trauma. It's a reality. I think it's an unfortunate reality because of the ubiquitousness of firearms in the United States, that we probably see our greater share of gunshot wounds and ballistics wounds here. And I'm not sure about other countries, but I can tell you that there is about one domestic pet dog for every 3 Americans. So we love our pets here, and perhaps we have a greater representation of dog bite trauma than we might see in other parts of the world. But as Dr. Jeannie pointed out, there are universal themes when we look at the definition of trauma with domestic disputes, sports issues, work issues. So we have some common themes as well. We've had speakers, and Dr. Jeannie took us through the Italian experience in COVID. We are finding here, again, trauma tends to happen where you are. And with COVID, all of us have been spending more time in our homes. And so it's not surprising that we're seeing more trauma originating out of our households. And as has been mentioned by a previous speaker as well, that we are finding that it takes a little bit longer for people to present. People are traveling further distances as well. And they're less likely to have health insurance, we're finding, during these COVID times. We see almost 2 million eye injuries, and about half of these are seen in our emergency departments, and the others are seen primarily in our offices and other less intense facilities. As has been described, we see in our country as well that overwhelmingly the patients are male and young and white in our country. And we see various types of injuries, including superficial injuries like corneal abrasions, but also foreign bodies, blunt trauma, and of course, open globes. When we look at the emergency room experience, we all know that the skills of surgery have been honed on the battlefields for millennia. But we in America have also patterned our trauma system on lessons learned in war. From World War II, when we primarily treated people on the battlefield and did the best we could in the war theater, to lessons learned in Vietnam and Korea, where we started having regional care facilities, and as my dear colleague, Dr. Mazzoli describes, echelons of care where we stabilized and then transported for further care as needed. And we've refined this now to very sophisticated ways of getting our military soldiers out of the war environment and back into the domestic environment for the totality of their care. And we utilized some of those lessons to organize our National Trauma Center system here in America. And this is a really nice article out of the Chinese Journal of Traumatology that I will summarize here for you all. In 1966, the Committees of Shock and Trauma, which were part of the National Academy of Sciences, published a sentinel volume of Accidental Death and Disability, the Neglected Disease of Modern Society. And in this tome, they called for an increased role of the federal government to standardize trauma systems. Out of this advocacy came the National Highway Safety Act of 1966. At the time, motor vehicle accidents were a major source of ophthalmic trauma. And so from this came our initial grants that funded the early trauma system. And here in my native Chicago, Cook County Hospital was the epicenter of the first statewide trauma center in the United States. Later on in the 70s, the American College of Surgeons gave more granular detail to the designation of our trauma centers, from the top level, level 1, where we had the entire management system of trauma from the time the patient hits the door to the end of their visual rehabilitation, and then stepping down accordingly to different intensities of level trauma in our country. And we have found that this trauma-centered system has been working well for us, with a decrease in mortality initially, as well as better outcomes over the course of the first year. And we have found that both our morbidity and mortality from general trauma has steadily decreased from the 1960s. However, there are areas that are still challenging us with this system. Despite the initial call for federal standards, we still have not realized this goal. Our access is uneven. We still have 50 million Americans who are greater than 1 hour from even a level 1 or level 2 center. Yet we have 40 million Americans who are with less than an hour from more than 20. So we have uneven access. If you live in the Northeast, areas like Boston, New York, you're in good shape. If you live in some of our more rural areas, in the West, particularly Utah and Wyoming, you are not as close. It's also expensive. We are obligated to treat all emergency injuries, regardless of the ability to pay. With the corporatization of medicine, for-profit hospitals are getting out of the business of staffing trauma, which further adds to the burden of our academic centers as well. Within our trauma center, we still have not been able to establish a designated ocular arm. The going motto for trauma care is save life, sight, and limb. But in reality, in most cases, the emphasis really comes down to life and limb, and sight is secondary. We also are seeing in the United States a crisis in the willingness of American ophthalmologists to provide ER and inpatient call coverage. The Academy established a work group 2 years ago to address the reality that fewer of our members were willing to provide hospital coverage. This increases the burden on our academic medical centers, and it doesn't do very much for our reputation as ophthalmologists within the broader house of medicine. What are some of the reasons? We looked at and detailed with our surveys here. We have less of a need for hospital privileges, so therefore our ophthalmologists are not tied as much to the hospitals. And in many cases, the requirement of providing hospital call comes along with your hospital privileges. So as ophthalmologists have migrated away from hospitals, they no longer provide that call. There are economic pressures, both in the fact that the trauma call is very poorly reimbursed in most cases, but also there are opportunity costs when you're providing care in the ER, you're not in your office, you're not in the operating room taking care of your own patients. And these cases, as we all know, are ripe for litigation. You know, we don't sometimes have a good history. There are steps that are made in the heat of the moment that may come back to affect us as well. And, you know, trauma call is usually after hours, as we've talked about. This has ramifications for how you feel the next day and contributes to burnout issues as well. I was intrigued by Dr. Talma's talk, speaking of, and I know this as well, that, you know, with the increasing trend towards subspecialization, it's very difficult to find ophthalmologists who are capable and comfortable providing care for anterior segment, posterior segment, and orbital trauma all at once. So I think, you know, we could use more of these South African residents in our country to help take care of all this trauma at one time. But the reality is that emergencies happen all day, every day of the year. And we find that 20% of sentinel events in our emergency departments are related to the absence of specialty coverage. And the reality is, if our community ophthalmologists aren't available, there are other eye care providers who will probably be quite willing to step up and take that call. So the work group recommendations were that member education on most ER and inpatient conditions is paramount. We don't see the volume in the United States that our colleagues across the world do, as has been described by Dr. Legault as well. We really need to focus on that. We also came up with some policy strategies to reduce the call burden. We find that about half of ER ophthalmic visits are really not true ocular emergencies. Is there a way we can triage these in a better way, make offices more available to take walk-in patients to decrease the burden on our emergency rooms? In addition, we have a hospitalist model here where internists no longer follow their patients into the hospital setting. They transfer their care to dedicated hospitalists. And there seems to be some interest in exploring an eye model of that same thing, where we have dedicated ophthalmologists who only take care of patients in hospital settings. And in addition, as Dr. Legault described, our military ophthalmologists are probably one of our greatest assets. And so I think we need to increasingly leverage their capabilities and their willingness to take care of our civilian population. I think that's a win-win for everybody. Speaking of our military ophthalmologists, I think that the levels and the echelons of care really come into play when we see mass casualties and polytrauma, as for instance, like we had in our Las Vegas shooting a couple of years ago, as well as Boston Marathon. And I think these are situations that most mimic the kinds of decisions that have to be made in the battlefield. And I think that we are better served by a synergy with our military ophthalmologists, and many of the tools that we use in our mass casualty situations are derived immediately from our military ophthalmologists. So physician education, we spend a lot of time at the Academy. This is really, if you want to think about it and cone it down, this is our primary mission. It's what the Academy does. And we focus on making sure our members are good diagnosticians, that they know how to treat, and that we don't forget the role of rehabilitation. Intraocular foreign body is one of the top 3 missed diagnoses for ophthalmologists in the United States. And so trauma is up there for one of the things that we tend to miss in many cases. We have lots of educational offerings, and I will emphasize that the vast majority of our trauma content on the American Academy's website is open access. You do not have to be a member. About the only thing that you cannot access is a couple of courses and the access to the wills manual, because we pay for these things and we cannot make those available to everybody. That's a member benefit. But just about everything else is open to anybody across the world. We have collaborated with the American Society of Ophthalmic Plastic and Reconstructive Surgery to make a separate center for orbital trauma. Open globe, as we have mentioned before, we don't see quite as much of these types of traumas in the United States as some of our colleagues across the world, but they are probably one of the most common emergent situations that we encounter. So we have many videos on the website that will take people who don't see these types of traumas very often and give them some guidelines for this situation. And again, we also focus on rehabilitation. We sometimes forget that aspect of our trauma. We also educate our patient and public population through our iSmart arm. And so when we talk about protecting sight and empowering lives, this is what we mean by protection. And so when do you wear eye protection? Well, you wear eye protection when you're doing dangerous things, no matter where that is, whether it's at work or whether it's at home. And we have all of this information on our iSmart website to help our patients recognize the hidden dangers in their everyday lives. Our recreational activities, there's an old saying, it's all fun and games until somebody loses an eye. And that's actually literal in our case. There are a lot of recreational activities that we pursue that we think of as relatively innocuous, but they're not. And we try to raise the level of public awareness on this as well. Every January 1st and every July 4th, we have a campaign on the hazards of homemade fireworks, as well as the hazards of a cork coming out of a bottle. We showed videos on how to properly remove a cork from a bottle, and again, increase public awareness as well. Sports are another source of trauma. Interestingly, basketball, it's always a great trivia question if you want to ask somebody in the United States, which sport is the most dangerous to the eye? And people don't think about basketball, and it's obviously not from the basketball itself, it's from the activity under the basket, or what we call in the paint, with lots of elbows and lots of fingers. And we know that people get blowout fractures and ruptured globes, and certainly corneal abrasions. We saw, unfortunately, in our country last year as well, ophthalmic trauma come to public awareness because of the use of rubber bullets by law enforcement for crowd control. And we had over 30 ruptured globe injuries from rubber bullets within the first week after the death of George Floyd and the protests that arose from that incident. So we immediately published online information for people who were protesting how to protect their eyes, and also to call on law enforcement to consider other methods of crowd control rather than the non-lethal rubber bullets. This article just came out, excuse me, about a week and a half ago, looking at the United States Eye Injury Registry, both past and future. And we see here some very familiar authors, as been described, very energetic members of our ASOT organization. And the original trauma registry was established by ASOT back in the late 80s. And a lot of great things came out during this time from this. We came up with our Birmingham Ocular Trauma Score, the General Ocular Trauma Score. We looked at epidemiology and determined trends in injuries and the nature of injuries and who was getting those injuries. And we used this information as the basis for a number of policy recommendations. However, the organization went inactive in 2013, and we didn't have the benefit of this type of registry. And while there were many other types of databases, these primarily did not address the ophthalmic arm of trauma. And more importantly, even the Academy's IRIS registry, which I believe is one of the largest clinical registries now in the world, because our academic centers for proprietary EHR reasons have been traditionally locked out of the IRIS registry, we've lost, or we don't have traditionally access to that type of information. And so even the IRIS registry suffers from a lack of ophthalmic trauma related to our academic medical centers. And we still have a lot of questions that we'd like to answer as it relates to ophthalmic trauma. Dr. Ocampo mentioned the difficulty in funding, and you know, we see a little bit of that here in the United States as well. We all have these kinds of questions that we want to have answers to. And so the American Academy of Ophthalmology is helping and partnering to give as many resources to a resurrected ASOT as we can, so that we can resurrect this registry, because I think that ASOT is probably in the best position to do this kind of work going forward. So we're going to try to give them as much help as they possibly need. And so we know, I'm really excited, and it was a real pleasure to hear Dr. Legault earlier today, because I know what great hands we are in. So I'm very excited about the renaissance of ASOT and working with them going forward. So our take-home messages for the US approach to trauma is that, of course, ocular trauma is a public health issue. And though we have a robust tiered trauma system in the United States, we still have challenges with coordination and funding, and remaining vigilant to make sure that the ophthalmic arm is represented both at the policy level as well as the clinical level. We have work to do with our own members to encourage ophthalmologists to maintain their ties to their hospital ERs and inpatients. And we need to continue to work with our government and our professional societies to establish some national standards. We continue to increase an emphasis on our education. Again, we tend to see a lot of trauma as residents, but depending on our practice situations, we don't tend to see as much depending on where we are and our practices once we get into practice. So we have to make sure we maintain those skills. And don't forget about protection. We hope that we put ourselves out of business one day for ocular trauma. We know that's not a reality, but the more that we can emphasize the role of protection, the better off we'll all be, and we'll fulfill our professional mission. And I really love the emphasis that I've heard from all the speakers today on some of the silver linings of COVID. It has further flattened our world and allowed us to collaborate even more easily as we are doing today. And that said, however, I cannot wait until we can gather again and we can all see and give each other a hug. I want to give thanks to Dr. Rob Mazzoli, who helped frame my thought processes on this talk and give the military perspective. And I also want to acknowledge the thoughts of David Park, the AAO CEO, who helped, and Dale Fajardo, our education vice president, for helping also to educate me on the Academy's perspective on ophthalmic trauma. And again, to the organizers of this course, so many thanks to you for inviting me to be part of this course today. It was the best way of starting my weekend here in Chicago. So thank you very, 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 very much.
Yes, thank you. Yes, sir, wonderful, Tamara. Heartiest congratulations. I think I keenly watched whatever you presented, and I think I'm happy you are making really a global picture and associating with every trauma society and specifically highlighted what American Academy is doing. I'm also closely watching, and I'm working with Ravi Goyal sometimes, and he mentioned during the rubber bullet injuries, and they quoted the New York Times, which was there. We had a problem in Kashmir, so I did a lot of pellotocular injuries there. So I'm actually following Ferenc Kuhn's idea of primary wound repair immediately, as you said, 24/7. And our hospital per se, and few hospitals in India are doing 24/7. And I think also we want to do the secondary intervention in 6 to 7 days as a second window, and not even wait 2 weeks. And that's what I'm happy to continue what Ferenc Kuhn says. And I think the reason is, I think if you wait too long, we have a problem of repairing the retina. And if you do too early, there it's a problem. I think 6 to 7 days is good. So I recommend. In India, we have a problem because of the sometimes violence happens even in the clinics if they expect some vision, and they all come with no PL and they want dramatic vision. So I think we have written several articles in the press saying that following injury, if you have a no perception of light, we can operate, but please don't expect miracle. Even though a lot of patients can improve. I think you highlighted all angles, including teaching and also the various articles in the wiki, also what you mentioned, and then iWiki, as well as in the American Academy. I think it's great. Now probably Kendrick and Rupesh will lead the discussion with the panelists. And there are several panelists from all over the world and all the continents we have here. Again, once again, thank you for honoring us by giving this oration on behalf of the Asia Pacific Ophthalmic Trauma Society. Thank you. Kendrick?
Yeah. Okay. So thank you, Professor Natarajan. So I think we listened to really great talks today. I think just a really nice global perspective, and also highlights a lot of common issues that we have. I think what the COVID-19 pandemic did was not only did it increase certain types of trauma that we've seen, like domestic trauma, and in some cases even sports injuries because of finding things to do. But I think it also highlights also some issues that COVID has caused in terms of lack of access to care or unwillingness to get timely care. And it's also impacting our training, and also even for surgeons who are established, who are already operating on their own, it's just losing the practice, losing the groove, and losing their surgical skills as well. So yeah, Dr. Rupesh, do you have anything you want to add in terms of starting the panel discussion?
Yeah. Thanks, Kendrick. And I'm really thankful to all the speakers. I really thank, first of all, Professor Ganga for setting it up. And this is really having all the speakers from all over the world. So I think as Professor Fountain did mention about having those African ophthalmologists in US, and none of the ophthalmologists is probably completely trained about the trauma. So I think that goes to a fundamental question to almost all the panelists here, and which Professor Ferenc Kuhn has been talking from 1992 probably, is about imparting the training to the fellows or the colleagues or the residents about the trauma. And if you submit a paper on American Academy platform also for a free paper submission or a poster, you don't even find a tab of trauma. There is no separate category or section of trauma there. Whether it is EVRS or whether you talk about any of the other platform, hardly you will see. And then the trauma, you have to fit it into general ophthalmology or vitreoretina or neuro-ophthalmologist. You tell me how many centers are there in the world with a proper trauma center with the trauma fellows. So I was the one fellow with Professor Ganga and inspired by Dr. Natarajan, and who did only trauma in my life, and probably more than 1,500 cases of trauma management I did. I did some bit of orbit, but we could not manage to get that trauma fellowship there. So what is the stand of all the different continents about creating a trauma fellowship program? We don't have at all over the world. So that's my first question. And at this level, probably all the leaderships are here. So many presidents are here. What are your thoughts on it? How do we move forward? Because we have heard about it. People speak about the challenges, which is the lack of training, lack of motivation, lack of SOPs, lack of structured training program. But we need to probably take a stand at this stage How do we take it forward? So I have been demotivated for many years now. There is no support for trauma, no incentive for doing trauma. How do we take it forward? Because we will be having this symposium time and again. But unless we come up with a training program, whether it starts from AO or whether it starts from RENSCO, I have spoken to AO, I have spoken to RENSCO, but nothing has moved forward. So just your thoughts.
Yeah, but we have a Ferenc School here.
Yeah.
And we have Tamara, I think, and also Hugo made a presentation on PETIT and other programs where Hugo.
Hey, Professor Natarajan, we have iGates program also. We have a trauma registry. We have created that. So the registry has been there. USCIR been there. How many people take it up? Ocular trauma score has been there. How many people really take that? None of my residents know about using ocular trauma score. And it's like cataract, people will know everything. Retina, AMD, they will have all the things. But we don't have that thing for the trauma management. So I think how are we going to structure it? And at this level, we need to probably think about how are we going to define the trauma in the next 5 years. So it does not be ASOT. So I think everyone need to join hand together. When the ASOT was formed, APOTS did suggest it, APOTS, ISOT, ASOT, everyone need to collaborate to take it forward. How do we take it forward? So that's the most important thing is the skeleton. If we can come up with a skeleton, then we are ready to kind of take it forward. I've worked with Grant Justine. We are working with Fasika. We are ready to take it forward, but we just need to...
Let's hear from the masters, Professor Ferenc Schoon and Dr. Jose Dalma, please.
Appreciate the discussion, and Tamara can follow up with all of our other presidents. So, Ferenc?
Well, I think this is really the main question. How do we teach the next generation? And I see several problems here. One of them is, as we heard in a number of these wonderful talks, the lack or the inappropriateness of teaching, not enough opportunities to learn trauma care. And Professor Talma's talk had a very important line in it, which said, and this is why I'm mentioning it to add another layer of the problems to this, is that in South Africa, at least, the ophthalmologist who treats trauma treats a lot of cases. So it's not a lot of people doing a few cases, but the other way around, which is the ideal. It should be the experienced one, not the resident who was not trained. So my addition to the problem is those who are training, are they trained themselves? Because I have certain doubts when I travel around the world, used to, and I go to ORs and talk to people who are supposed to teach or even teach, and then I ask them a few questions, for example, as Gary mentioned, about suturing. Who the hell is teaching suturing today? The answer is almost nobody. So the only goal of those who do the primary wound closure is to have a watertight wound. Of course, it's important, but is it sufficient? Obviously not. So I wish I could have an answer to this. Trauma fellowships would be a very good solution, but we have to be realistic. And this also came up a lot, funding. Who will fund a trauma fellowship, which, as we know, in most cases must involve other things as well, not just trauma, because in most countries in the world, you will not be able to supply enough material, fortunately, for somebody doing only trauma. And also, nobody should be doing only trauma because you have to do other things to keep up your skill level, etc. So we also know, if you go back and look at the ISAT meetings that I was involved with, it used to be a standalone ISAT society meeting, but in the last, I don't know, 15, 20 years, you could not organize one because you would not find sponsors. There's no money in trauma for the companies. So they will only come if you work together with another society and the financial support comes to the trauma part of the meeting through that other society. So I'm sorry I offered no solution, just a few thoughts. But let me finish with another thing which already came up, and I want to emphasize this, and that goes back to the American Academy. We have been trying for many, many years to make trauma a standalone subspecialty. And obviously, we have not been successful. So, for example, if you submit a course to the Academy for this year, as in the past years, there is no trauma topic that you can choose. You have to go with anterior segment, something, or retina. And it may be true for certain traumas, but most of them, because trauma cuts across all subspecialties, you have to force your talk into something, some category which doesn't necessarily fit. Also, the Academy doesn't have a standalone book on trauma management. The posterior segment is hidden in the retina section, the anterior segment trauma in one of the anterior segment books. So by doing a standalone trauma, we not only give more accurate categorization, but also emphasize the need to have it as something that people have to be trained for.
If I may, most of us that are here in the panel have taken trauma more or less as a hobby. I mean, we're here. None of us is a professional. Well, at least most of us are not a professional, exclusive trauma surgeons. We do trauma basically as a hobby because nobody will pay for it. Unfortunately, the hospital systems around the world are not geared to pay a permanent staff trauma surgeon to be on call. No, it just doesn't happen. At least in Latin America, the way the systems work, I only know of one program in Guatemala that actually funds a special physician to deal with trauma 24 hours a day, 365 days a year. That's the only program I know here in Latin America that has that. So as long as a physician cannot make a proper living doing exclusively trauma, none of these initiatives will work because, somebody has to make a living out of this. So unfortunately, if there's no money, if there's no investment in this by the hospitals, by the government systems, it's going to be tough to have it as a subspecialty.
I think one of the things which Professor Huayan showed at the beginning of his talk is a very beautiful video by Bill Gates, is about building the systems. I think we are talking now about the coronavirus pandemic, and we are already talking about having the systems in place. So this trauma, according to me, is an ongoing pandemic for many, many years. And we've been talking about it. So I think, as Professor Dalma rightly said, if we need to build up a system, I think we need to put up things like, we have to come up with some solutions, whether it is to be blended with oculoplasty with trauma, or whether it is to be general ophthalmology with trauma, something like that. Some creativeness, some innovativeness has to be done. Otherwise, we'll be still talking probably the same thing. So some systems need to be created if we are not going to repeat the same symposium after 5 years again. Yeah. Yeah. You
yes,
need
Dr.
to.
Talma.
Yeah, wait. Wait, Professor Talma.
Rupesh?
Yeah, Professor Huayan, just a second. Let's.
Yeah. I want to say, I have a little bit to talk. So just now, Kun gave us a good idea. So I think for the next generation, for the young residents, how to train their ocular trauma surgery or diagnosis or treatment. From the presentation of the president of AAO, and told us, in different countries, the ocular trauma cases are different. So if they're different, so I have an idea. So APOTS, like a good organization, like a good team. So all the young residents in the world, if they want to get the training of ocular trauma, they can apply for this to the APOTS. And then almost the experts from APOTS can, accept some of them. And for me, if I like to accept one or two fellow for ocular trauma surgery training, I will, for call Rupesh, Ganga, Natarajan, I want to get one fellow for ocular trauma. And in my hospital or in China, I'm sure but the training fee will be free, and the fellow just paid, for the room, for the flight tickets. That's it. It's very cheap. So depend on their demand, rupees. So I think this is a good idea, maybe. Thank you.
I think that's a great idea. Sorry, go ahead. Go ahead. I think all of you highlighted several things, and I think Rupesh and Dr. Ferenc was pointing out that Academy did not have a trauma category, and we have been sneaking in our course, general ophthalmology section. And thankfully, the Academy has been accepting our courses and Dr. Ferenc's courses also over the years. But one major thing was it was always the last session on the last day during the era of physical meetings. Yes. And people are busy running around catching their flights. So I think one way is centering it somewhere in the beginning of the meeting, number one. WOC, when they conducted the ICO this year, they did manage to create a section on trauma. And believe it or not, it was one of the most well-attended courses, and we were able to submit a lot of courses. And we got speakers from around the world to join the trauma section courses at the WOC. So I'm sure the American Academy of Ophthalmology, if we have collaboration with the president, the CEO, and practically all faculty who do trauma, we should be able to create one. And the advantage of creating a separate category is the sponsors of the meeting themselves start taking note that it is one of the important sections, like retina, glaucoma, pediatrics, plastics, so on and so forth. And that could be an indirect route to sponsorship for future courses. And Professor Huayan mentioned about sponsored fellowships. We have APAO sponsored fellowships in various subspecialties where, like he said, institutions accept a fellow. We won't charge them for anything, but they can come travel on their own, stay on their own. We can train them. So likewise, we can have an APAO collaboration where these societies recognize centers of excellence with individual excellence in each of these institutions. So prepare to train a fellow. And we can have a global network where a guy from Singapore can go to Germany, a guy from France can go to Australia, accepted by a mentor who can train them and guide them in trauma. These are two suggestions which just came to me. Tamara, go ahead, please.
Yeah, I was just going to step in here that I think as been described by everybody, it really comes down to funding on some level, whether it's government funding, whether it's funding for individual physicians to take call. Most of our level 1 trauma centers, they pay call for many types of services, but it is really unusual for ophthalmologists in particular to be able to negotiate with their hospital systems for pay. And we are prevented from unionizing here in the United States. And so, I think there's two parts of the problem is that we can provide all of the fellowship training, all of the education that we can muster. But at least in the United States, we still have the issue that our members, once they get that training, are going to be reluctant to provide it because trauma is so poorly compensated and it's so inconvenient. That's the reality. But you know what? You get what you pay for. And neurosurgeons who are paid to take call, they're there. And no level trauma center can be a level 1 trauma center without that service. My understanding, and I'm not the expert here, is that while the ACS establishes what trauma centers should have in order to receive that designation, I don't know that there's any mandates for that. And so we have a fragmented system. We also are facing the reality that we have an entire DC office, Washington, DC office, dedicated to advocating for a favorable regulatory environment for our ophthalmologists, just to get paid to do cataracts and glaucoma and things in our offices. And so we are facing some headwinds going forward, even more so than usual because of the bill that all of our governments across the world are going to have to pay for the COVID coverage. So, I listened to the discussions here, and I know that it's always been challenging. It's going to be that more challenging at least in the next few years as our governments are distracted with issues elsewhere in our public health arena. But I think, when I hear you all talk about, the lack of a trauma silo at the academy, and I think about that, and I may be the president, but this is a well-oiled machine run by David Park and our vice presidents in our San Francisco office. But it seems as I listen that it doesn't really cost that much money, if anything, to organize our academy meeting in a way that can provide a little more emphasis on the coordination and the collaboration that trauma involves, because it really does involve everybody from all facets of the ophthalmic sphere. And so, I'm gonna talk with Dale Fajardo and see, how difficult would it be to reorganize things so that we take trauma and give it its own home. I know you probably have done that, so I'm not going to act like I can do things that you all haven't done before, but I certainly want to partner and do what I can to help in that regard.
I think that's wonderful.
I think Dr. Talma would like to say something too.
Yeah.
Could I maybe say, I think let's start off in terms of training. In the basics, shouldn't we start at piecemeal? We can't have a big bang created. Trauma is a multidisciplinary sort of treatment, I think, all over the world. So it's very difficult for one person to do everything. So therefore, I'm thinking it should be nearly a required add-on to each discipline, to the retinal surgeon, the anterior surgeon, so to have a component dedicated to, I'm just asking, to trauma. If we could have in our basic training a schedule of minimum requirements that must be trained for residents in anterior segment, in the iris, in the lens, in the retina, and the orbit. And one component should be it. And if we could have a work group creating such a schedule on what is the minimum required that should be in the exams, and there must be questions in the exams. And then we can add it to every subspecialty and fellowship, a small component that should be trauma related, because the principle, as Ferenc has shown us, is the same. And if we understand that and make it up, enforce it, then we're going to get much further. As far as funding is concerned, we managed in our country to make emergency treatment legalized, has to be paid by insurance companies and hospitals. So for us, the initial treatment, if you have an open globe, you fix it over the weekend, there's no problem in funding and payment. The long-term treatment might be problematic, but that's also legally already been included. So that's a good way of doing it, starting it on emergency. But I would really think we must have a stepwise, start with the training minimum, small component per discipline, and then we get our foot in the door. Thanks.
Yeah, so maybe I'll just share what Dr. Talma said and something which we have been talking about it.
A concept which will be looking like something like
sorry,
this.
This is the video maybe, but just wanted to stop video. Okay, basically, as we have been talking about the trauma unit and what can be done there is to put this thought is any hospital should have a trauma unit. All the patients of trauma should go there. So I deal with other subspecialties uveitis, which is again a very small number of patients. So even if you start with all blunt trauma, open globe trauma goes to that, automatically you will see that clinic being flooded after the end of 3 months or 4 months. Probably he will be seeing 20 patients every day because there will be some follow-up patient and some new patients. And that person of that hospital becomes the center person. And eventually he's going to triage the patient. So any patient with history of trauma goes to him as a fresh case or as a follow-up case, and then continue with it. After that, once it becomes more complex, whether it is traumatic endophthalmitis, blood fracture, or something else, then he lies with the other subspecialty colleagues. So that's how probably a care model can work. Probably Dr. Ginny wanted to say something.
Gianpaolo wants to say something.
Oh, Ginny, go ahead.
Yes. Everything you said, I agree on. What I like to point out is that obviously different places have different realities. So, for example, in Europe, and I think in a lot of Western world countries, we are victims of our own success in preventing injuries. So there has been some very strict regulations with with severe fines for not applying the rules on the workplace. So that now the number of injuries on the workplace has dropped dramatically. Now, that is something we all strive for, but we also are penalized by this because obviously we lack the numbers of traumas that other people have and that actually allow you to train. So that is one aspect of the question. And that would necessarily require having two different things. One is having obviously different sorts of training, and Gary was pointing out to a number of virtual models. I believe that Ferenc was saying something quite appropriate when he was saying people don't know how to suture anymore. Now, my trainees sometimes have difficulty just inserting a secondary lens because they don't know how to suture. They haven't been trained because they do phaco's all the time. So it's necessary to go back to basics and to learn this. And you can do this on animal models very easily. This is what we all did before we started actually going on to human beings. So that's one aspect. Training doesn't necessarily have to be in the first instance on trauma cases, especially if you don't have the trauma cases. The second thing is that because certain countries do not have either the funding or the numbers to justify the existence of a dedicated trauma hospital within department within each hospital, then we should geographically organize centers which will serve wider geographic areas. For example, we can have one in the southeast of England, we can have one in the Midlands, we can have one in the north of England, and so forth. The same thing for Italy. So in our countries, the distances are not great. So you can go from Milan to down to Sicily. It's an hour flight, 50 minutes. So we can have lesser centers and well organized in which you have properly trained surgeons. Another aspect, again, is that we are fighting against a consumer society, where, as Tamara was saying, people will go where the money is. It's most of the ophthalmologists. Why do a lot of ophthalmologists go from retina to well? Not many that I know of, fortunately, but they choose refractive surgery. Well, because it's easy and it's easier and certainly more lucrative. So again, now the tendency is to have subspecialties. So people do only cataracts, only glaucoma, only cornea. Here we're talking about pole-to-pole surgeons, as we were. I mean, in my days, we did everything from and Natarajan, and Cesare and first, we did everything from because when you're doing a trauma, you can't sit and say, wait, I'm not going to take the cornea out and put it keratoprosthesis because I need the cornea surgeon. You don't have the cornea surgeon. You don't have the time. So you have to know how to do that and so forth. So if you have to put in a valve because you have a traumatic glaucoma, you have to know how to do that. So we're fighting against a well-set standard ideas that we have to subspecialize. So the trauma surgeon is the opposite of subspecialties, because we do everything from pole to pole. So there are many issues to consider. Some of them are difficult to get around, and again, funding and political lobbying are essential to getting at least this speciality recognized and having a dignity of its own, because it does have a dignity of its own. But until we finally get the national societies and the political power behind that to recognize it. Now, Tamara was talking about the 1966 Safety Act for the highways. That came about because there was strong political pressure on the government to do something about those accidents. We had to do the same as far as eye trauma was concerned. We had to lobby. We have to get the government to intervene.
those are really excellent points, and I think a lot of us to kind of take the points from this, and maybe because I know this will go on for the whole night, but is it possible that we set up, and with due permission from APOTS president, we set up a task force, a global task force with some key members from all the different societies, and I did requested for it, and we continue to brainstorm it and come up with certain kind of a guidelines, because this is not going to be possible, and where we kind of find the challenges and then what are the ways ahead. So what do you think, President APOTS?
I think we have 6 presidents here. We can be the whatever the supervisory whatever capacity. We're not really going to work as now. The whole program is done by all of you. We will come and maybe fine tune it, as Dr. Tamara presented a lot of things from academy, which was done for a lot of time. I think quite a good period of time the work has been done. Similarly, I think all presidents can head this, and we can have the global thing as task force, as you said, and from APOTS like you and Kendrick can be there, and from like that EVRS, from the APTO, then AAO and ISOT, I think we can have, and also from Hugo's place and South Africa. And Africa, I said a lot of vacuum surgery. When we are trying to do some rest of the world, I think we have to keep Africa in mind to pull them up to our level, so that we are all, as Ganga put it in the notes, that we should have a flat thing. So I think it's a good idea to have that from APOTS. I think you and Kendrick can be the 2 members for the task force. Like that, other 5 societies from China too, from EVRS, from AO, ISOT, and we can select that.
Yeah, I think this is an excellent idea, and while I hate bureaucracy, but I think the reason to have all the possible societies sign up to it is because that would create the force for politicians to do something about this.
Yes, I think so. And I think the AO, ISOT from the Northern America, and then we have South America, then we have Africa, we have APOTS, the entire Asia Pacific, and what is left? And China is there, another 1/4 of the world.
We need somebody from Antarctica, and then we cover the globe.
Oceania will be remaining. Last continent, Oceania will be remaining. But anyway, Dr. Ganga, sir, you have any of the further points? And because
we formed the global task force.
Yeah.
Presidents, as you can call it the patrons or whatever, and have a force of 2 from each. And then, as Ferenc says, under the 6 societies, all other societies has to be a associate, where they can have academically oriented 2 ophthalmologists as a subcommittee with you, like ocular trauma, oculoplasty, vitreoretinal, glaucoma, whatever. Because I think, as Gianpaolo said, I think we 6 societies have to see the global, like I'm talking over the globe, the global ophthalmology, and plus we have that other societies joining us under us, so that we have a real global task force for the globe.
Sure. We'll do that. Sir, you're muted. Dr. Ganga, you're muted.
Sorry, thank you. So before I say anything, maybe I'll invite Professor Caroline Chi, Hugo, and Gary also to say a few things, what's on their mind, before I just put about 3 particular points across. Caroline?
Yes, I was, can you hear me?
Yes.
Okay, I was actually starting to type out a suggestion, which was if we could look at the economic cost of loss of vision from ocular trauma and use those figures, so that data, to advocate for to our governments to provide financial support to institutions to be able to create positions for ocular trauma specialists, since that is really one of the problems to move forward. So really getting data on economic cost to a country.
I think that economics and quality of life is the very key important thing, and I think that including that component will definitely give a bit of thing to regulatory authorities and the government.
In fact, where I mean, I used to say this with orbital fracture.
So I mean, if we get
go ahead, Caroline.
I mean, if we get this from all the continents, I think that would be, I mean, I would imagine that would be pretty powerful.
Yeah.
Right. I think there are probably two arms to it. I used to say this with orbital fractures, that every single fracture we do and rehabilitate and send the patients back to the perfectly normal pre-morbid life, we say there's no residual mobility, hence there's no compensation. But that's a success in itself. And every single trauma which has been mismanaged or delayed managed and the costs that you're talking about, I think both the success and failure have to be valued in dollar values. And that message has to get across to the societies, organizations, or governments. I think that's a very good point. Hugo, would you like to say something?
Yeah, thank you. First of all, thank you for this great opportunity to show to Latin America in ocular trauma. I'm very happy because here all the world talking about ocular trauma, and Ferenc says there are many different societies. I think this only one society with different names, but the thing, the ideas is the same, and this is very important. I think that we have a problem in all countries is that ocular trauma is like the Cinderella of the ophthalmologist. And it's very important to show the government how much the cost and a blind in a patient of, I don't know, 30 years, 20 years old, is very old, very high costs. If this is the great opportunity to show in like a unit how important is training our residents, our fellows in the appropriate initial management of ocular trauma. So thank you very much for this great opportunity.
Gary, would you like to say something? Because you seem to have a wonderful training program, and I'd like to hear your perspectives before I just summarize into 2 or 3 points here.
Yes, thank you very much. I'm driving in to see my post-op LASIK patients, but I can still, education is the key. Everything that's been mentioned, we need to continue to educate, teach the basics of trauma, go back to suturing and getting practice with suturing. The next thing is uniting our efforts, staying united. I was at the AAO when we were in person 2 years ago, and Society of Military Ophthalmology had a trauma course. Same with, I think, Mass Eye and Ear, and then you guys. So there's various trauma courses, but we should unite and be teaching the same principles, working together to push our efforts, and just appreciate all your help and let me speak here today. So yes, continue to take time to teach the residents and continue to be role models and examples out there. Thank you.
Great. So yeah, go ahead, Franz. Yes,
just I want to add just 2 sentences. You were kind enough at the beginning to call me the father of modern traumatology. I appreciate that line very much. You have to change to grandfather. If what you said is true, then you are all my children. And I just want to say I'm very proud of my children, because both the organizers and all the speakers did a tremendous job. So congratulations to all of you, and thank you for the contributions.
You're still too young, so we cannot call you again grandfather, Ferenc. You're too young and too relevant. So no, I really am inspired by you, although I would strongly say that it's ocular, ophthalmic, these are all semantics, but we try to look at adnexal structures and we look at in unison. But I just wanted to get across these 3 points. Number one, we now seem to have a North American, or the American Society of Ocular Trauma, or ophthalmic trauma, which has been redesigned. There's Asia Pacific Society, there's a Latin American, or APTO, so to speak. Probably the 2 continents are Africa and Europe, which don't yet have trauma societies. And Ginny pointed out, it's a price they pay for the success. They've been reducing ocular trauma. But I think every country, every institution sees a minority of cases, but I'm sure if you put all your cases together, it's significant, and forming that society becomes an essential step towards better training, actually. So maybe I will probably extend on behalf of Professor Natarajan, Rupesh, and Kendrick from APOTS that we are willing to collaborate both with the European friends and the African friends to help form a special interest group followed by a society. So that's number one.
Thank you.
And number 2 is, like I mentioned, at WOC, I think now Dr. Fountain has said she'll take it up with the Academy Education Committee to try to see. It should not be very difficult. Sometimes the egos are more difficult than in the institution. And she is the leader. She's the leader. the leader and a friend, and with the vision that she has, having talked to all of us, to take the idea forward, in which Ferenc has been pushing for a long time, that try to create a section, and whether it's going to be anterior segment trauma, posterior segment trauma, primary repairs to orbital fractures and orbitofacial fractures, all that could be collated. And I think in trade and industry will look at that as a section, which hopefully will draw the attention for future sponsorship. And the third and most important thing is Hugo talked about it, Gary talked about it, simulated training. Yes, we do not have that for trauma yet. And I think we come up with a modular system where we have globe repair training, lid repair training, and maybe a fracture repair training, which is now available for a lot of things. And maybe if you can, all of us share what are the models you're working with and what are the deficiencies that we have and how we can collaborate and make sure that top centers around the world will have that as a center of excellence, will lead towards a curriculum for ophthalmic trauma training, which can be open to non-ophthalmologists, ophthalmologists, subspecialists, and eventually towards fellowship training. Those are the three things that I had. Thank you.
Ganga, can I make comments?
Yeah.
Yeah, so in continuation of what Giampaolo said, I want to remind, and I think Ferenc Kuhn also operates there, and I also operate in Lublin in Poland. There's an institute called Ocular Trauma Institute, started I think 50 years back, right? Ferenc, I think that Trauma Institute is the building, no, the one where Dr. Robert Redak is there. And your friend is the retired professor. I forgot. I think it's the trauma.
I don't know when it was established.
I think it's a very old building. Now they have moved to the new building with all, and it's in a trauma institute for several years. I think in Europe there is. I mean, definitely trauma would have been reduced, but I think, as you said, trauma institute will be there. And I think you said me to give some like the 10 years of experience of ophthalmic the APOTS, and then 25 years of Ocular Trauma Society of India. So I thought by 2030, we should have prevention of ophthalmic trauma in a big way. That what I meant by big way is every leader have to have something written about prevention of trauma rather than only talking about doing repair of trauma. And the other is protective gears with world standard uniform to the whole world. I know I'm in North America. That means US and Canada has a standard. And when I tell the patients wear a protective goggles and play shuttle or badminton or tennis, and they say, where is it available? India, it's not there because we don't have a standard for that. And I think we need for the whole world. And training residents, which you mentioned, and training ophthalmologists, not only residents, I'm sure who are in 5 years of practicing in rural parts of the, whether it's US or whether it's in India or Africa. I think we have rural part of the country which need ophthalmology, who like to have some refresher course on ophthalmic trauma training. And then you mentioned ophthalmic simulator, and I'm thinking of something to do with the artificial retina. I know unless the photoreceptor layer only is affected, artificial retina has been tried in RP and other degenerative disease. But I think for trauma, we don't have anything, and we have to work on something on bionic eye. I know the second site has gone bankrupt. Now Germany is working something, Australia is working something, maybe the US, they worked on brain implant, and that also the company has gone. But I think we have to work on something to do with the biological, retinal stem cell, and also genetic engineering will not come in this, but I think bionic eye will be maybe an answer for some of the trauma. So I think with this, I think we have to have a 10-year vision, and instead of calling only an APOTS vision, why not we have the 6 societies together as the global task force, which Rupesh is talking. Maybe have a 2-year to go through all this, because 1 year will be Dr. Tamara will be busy as the president of AAO. Trauma is not the only thing. She will do the entire ophthalmology. And I hope that, from AAO gives support to ASOT, APOTS, ISOT, and APTO. So with this, I hope, I know ISOT is the apex for everything, but we have some difficulty in having some local service. Each AO or APOTS, we have a excellent office support, which I think we have to give to ISOT, which I think this task force can take it up, so that whatever handicap Ferenc has, all of us can put our might and help along with the AAO to make ISOT as the apex, and under which we have this global task force. Friends, you're agreeing? Okay.
Man to that.
Good.
Anybody else with closing comments? And then I'll let Kendrick and Rupesh end it with the plan they're going to have for the global task force. Then we can start working with the research societies. Go ahead, Rupesh and Kendrick.
Yeah, before that, I think I request Tamara, you can think, I know you'll have, trauma will be, you have 12 months. And I think each month you have some targets in academia, I know that. So contribute sometime and tell us what you want us to do. We will do the homework for you. And as a president AO, you can present it to your team and we can collaborate.
All right, that sounds good.
Okay.
Henrik?
Yeah, thank you, everyone. And thank you for giving me the chance to speak. So I think what we need to do is consolidate all the opinions and also to set up a task force. So I think we need to focus on coming up with maybe a curriculum or a induction course in terms of what are some of the basic skills that we need to train. And I think we can start from the basic beginning. So when these residents come into ophthalmic training. The other thing is I think I'll plan with Rupesh to start writing up a commentary on all the different opinions and all the different factors that we've discussed today. And then we can go from there. So I think, yeah, it's going to be a great year ahead and look forward to working with everyone here for this. So yeah, we'll need your help. Dr. Rupesh, do you have anything to add for this?
Only few words. I think it's the beginning of a journey and I'm really thankful to everyone and all the mentors here. So look forward to travel this journey together with all of you. I think this is just the start, but we have to travel and probably carry along.
Yeah, I hope travel starts again soon, so we can see everyone in person.
Hope so. Hope so. I'm really. I mean, otherwise I was traveling every 2 days, and I'm.
Well, if you are thinking about the rules, the COVID rules changing for this year, I have a joke for you.
Yes.
So, an elderly gentleman has a prostate surgery, and as he's taken to the OR, he asks the surgeon, "Are you the one who is going to operate on me?" And the surgeon says, "Yes." So be careful, please. So after the surgery, the gentleman calls the doctor and says, "How did surgery go?" He says, "Very well. Can I ask you a private question?" "Sure." "About my sex life. Is it going to be the same now after the surgery?" And the doctor says, "Yes." And the patient says, "That's too bad."
Friends, I've got to, after that joke, I feel like I can actually do this. I was going to wait till we stop streaming, but you talk about your gray hair, but I want to just share with you here that you bear a striking resemblance to this guy right here. Wait, let me get him here. And I want to challenge you because I've never seen the two of you in the same room. So I'm pretty suspicious that you are actually this guy.
The Dos Equis guy.
I wish.
I'm sure that's you.
I think he has cognac in his hand, so I would gladly switch places.
And a cigar, yeah.
Beverage of choice. It used to be Dos Equis. Now he's gone over to whiskey. So.
Yeah. Dr. Kuhn can have a statement. He can say, "I don't usually do ophthalmic trauma, but if I do, I do it pole to pole."
There you go. Of course. That's what we need. We need a good celebrity spokesman.
Right. Well, maybe one from top sports, cricket and basketball and soccer and,
Wearing eye protection, of course.
Absolutely.
Yeah.
I know we are all over time and really appreciate the enthusiasm that all of us have. This was planned to be about a 90 minutes to 120-minute session. We've gone on to 3 hours. And I really thank you for the energy and enthusiasm. We could go on, but I think to be fair to all the celebrities we have on screen, I think we had a very, very good meeting. We had good observations, lessons learned, starting off with Huayan from China and how they really overcame the hurdles to the European experience. Dr. Talma, as always, I enjoy your slides, Dr. Talma. And believe it or not, you have really highlighted the excellence in South African ophthalmology and the pitfalls as well. And it's all about bridging the gap. And I think whatever happens in South Africa, we want it to happen to the rest of Africa. At this point of time, we still see it as a continent with a good opportunity to work with partners in the rest of Africa. And of course, Latin America, I had the pleasure of going there, and the warmth and the hospitality. And I think I see the Latin American ophthalmologists as one community in one country almost. That's how wonderful the continent is, really, really. And I only hope that we take all the discussions that we've had through Kendrick and Rupesh to really take it forward, have something really constructive, and how the Academy has probably every month has a different glaucoma, retina, vision, all these things. I suppose there's one for trauma, and we hope that at that particular month, when the American Academy of Ophthalmology plans a trauma month this year, we will all come back together again, see and show what we've delivered, and we'll probably have a true deliverable by that time. Kendrick and Rupesh, you promise?
Yep.
There you go. Anybody else wants to say anything? Yeah, so that's all. And we will close, yeah, if you don't mind.
Yeah.
I think
Thank you.
all the
Thank you, everyone.
3 cheers.
May I ask something?
Take a picture, please.
Thank you very much for the great meeting. But I would like to knock on the door of several of you for help.
Yes.
If we want to coordinate a proper coordinated African society. Maybe different objectives than the first world, but I think it's so vital. There's 1 billion patients and they really need help. And I think we will need some help of yours if you're happy to do so.
Sure.
We'd really appreciate it.
Actually, Dr. Jan Talma, I told you, your junior colleague who's on maternity leave, Dr. Sanita Mudle, we both did a survey together and I suggested to her already, and she called me as a patron or something like that. I said, don't want. And one of my fellows is there in, I forgot which country now.
I spoke to her earlier this morning and she sent me an SMS just now.
Okay. So, no,
Yeah.
I'm telling her to make a...
I make her do it.
I know you have 52 countries in Africa, which I already calculated, and I'm going to get one from each. And I'm also in touch with the African Ophthalmology Council through the ICO. When unfortunately we couldn't meet in Cape Town. Otherwise, the AOC, the African Ophthalmic Council, I've asked for, we have communicated, and I think because of this in between COVID, I think we're quiet. Maybe we should have a webinar only for Africa, the entire Africa. Maybe Rupesh and Ganga can think about it. APOTS to be there, but speakers should be only from Africa. John Talma, we will work with my Syed Asghar Hussain is there. I forgot which country he's in. He's active. He said he'll call from other countries too. I was there in Ethiopia also 2 years back. So we'll do that. And I think American Academy also has contacts in some of the African countries. So we can have one for the AOC.
Thank you very much.
Okay.
You certainly have my support, Dr. Talma, our support and my support.
Sure. So 3 cheers to all. Right?
Take a picture, Dr. Rajan. Take a picture together.
Yeah, let's take a picture.
Yes. All right.
Thank you. Thank you, everyone.
Thank you.
Everybody.
Take a picture. Take a picture together.
Yes.
You can do a screenshot.